We are live now, ma'am.
A very warm welcome to all the esteemed faculty members and the delegates for the AMOGS Emergency Obstetric Committee webinar, episode 15, with Dhule, Nashik, Malegaon, Jalgaon, Chalisgaon, and Nandurbar societies. A very hearty welcome from our emergency committee to all of you. Today, we have the stalwarts in their fields discussing about the safe motherhood as well as important lectures, which will be an academic bonanza for all of us and a very informative panel discussion. This webinar is a brainchild by Dr. Sneha Bhuyar, Madam. Let us all of the faculty members together for a lamp lighting ceremony. We take blessings from Lord Almighty and we will begin with the webinar. Thank you, Saiti. Let me take privilege to introduce the convener for today, Dr. Sneha Bhuyar, Madam. She has been in charge of the Foxy Breast Committee as chairperson. She is the governing council member of ICOG. She is also the national adolescent trainer for WHO FPI certified. She is the national expert of UNICEF, a peer reviewer of the Journal of Foxy, the AMOGS chairperson of the Medical Disorders Committee in the last tenure, and in the current tenure, she is leading the Emergency Obstetric Committee. She also leads the Mission Pink Health Committee and convener of the PCP entity cell of IMA. She is also a part of the working group on breastfeeding support. She is the founder president of ISOPA Vidarbha chapter. We welcome you, ma'am, today and we request you to please welcome the August gathering and introduce our chief guest and guest of honor for today.
Thank you so much, Monica, for that kind introduction. A very good evening to all of you. My respect and regards to our chief guest, Dr. Ulhas Patil. Sir, he was my senior from the same alumni. We belong to the same prestigious institute of BJ Medical College. And of course, I am very happy to welcome the guest of honor, my dear friend, Dr. Varsha Baste. And of course, my dear friend and batchmate, Dr. Arun More, who is the Dean of the Government Medical College, Dhure. So I welcome all the dignitaries. I welcome all the president and secretaries of the, Jalgaon, Dhure, Chalisgaon, Nasik and Malegaon, all 5 societies. I welcome all the members of these societies. I take this privilege to the welcome of all the esteemed faculty, especially who are the experts and the authorities in the field. I have invited Dr. Mitra Saxena, who is the chairperson of Foxy Practical Obstetrics Committee, and who will be speaking on the medical management of postpartum hemorrhage, and Dr. Shashilata Kabra Maheshwari will be speaking on the surgical management of postpartum hemorrhage. As all of you know that, the hypertension, hemorrhage and sepsis, these are the 3 main killers of our women. And that's a very reason we focus our attempts to minimize the maternal as well as perinatal mortality and morbidity. And of course, that's a very reason every attempt is made to organize such sessions all over in not only Maharashtra but all over India. And I'll be moderating the panel discussion on medical emergencies during pregnancy. So I thank all of you, all the chairpersons, all the panelists, of course, and all the viewers who have gathered here to listen to this very academic program. So I welcome all of you and thank for accepting the invitation and being here. And with this, may I take the privilege or opportunity to introduce respected chief guest, Dr. Ulhas Patil, sir, whom we know as the ex-member of parliament from Jalgaon he belongs to, and of course, a stalwart in his, the field of education. We can call him education, Shikshan Maharshi, we can call from KG to PG, everything he has under his leadership. And he's the chairman of Godavari Foundation as well as Godavari Engineering College, Agriculture College, as I have said. KG to PG, everything, a mentor to IMA Jalgaon, and of course, above all, a very kind human being, very approachable. So with this, few words, I would like to welcome Dr. Ullas Patil, sir, and we would like to listen to your precious words. Over to you.
Thank you, respected Madam Dr. Sneha Vyar. First of all, I welcome all the members. We call it a JDNN, that is Jalgaon, Dhule, Nandurbar, and Nasik. Members of course, of this AMOGS society, and welcome to Dr. Varsha, who is my classmate, and respected Dr. Arun More, sir. He's also from BJ Medical College. So this is a very important and precious topic for all of us, since we all are facing such emergencies, which even corporate people have not faced, but because we are getting the patients from the all tertiary centers. So this is a very good opportunity given by Dr. Sneha Bhuyar, madam. I have come to know that she is going to contest for the post of vice president, and definitely she is very meticulous, efficient, and hard worker in her all activities. She has taken as a responsibility. She has completed all the responsibility with due respect of all the members of FOXI and also members of AMOGS. So she is going to be a very good custodian for all FOXI members all over India as a vice president. And definitely we all will definitely support not 100%, 200%, meaning our colleagues from all over India will also be motivated to support Dr. Sneha Bhuyar for her future endeavor. So I'm humbled to be the chairperson, this is the guest of honor for this event. And of course, since I'm a seasoned politician, the welcome speech should not be more than 3 minutes. So I really congratulate all of you, and I'm thankful to all of you for giving me this opportunity as a guest of honor for this emergency obstetric committee meeting of JDNN. Thank you.
Thank you so much, Dr. Ullas Patil, sir. In fact, we are humbled and privileged to have you as chief guest for this program. Thank you for your precious words of guidance. Now I take the opportunity to invite the two dear friends who are, whom I have invited as guest of honor. Both of them are stalwarts in their own field. The first one is Dr. Varsha Baste, and the second, Dr. Arun More. So I would like to invite Dr. Arun More, who is, a very dear friend, my classmate. Of course, he's now a big man, the Dean of Government Medical College, Dure. And of course, he's holding the post of Professor and Head of Department of Obs-Gynae at the Government Medical College, Dure. And he's not only expert academically, but also a very good expert, operative surgeon, and a very good orator as well as, of course, a very good teacher, I would say, a mentor and master trainer to many. He's the president of district PCP NDT, and of course, so many accolades to his credit he has. But I would like to listen to your precious words, Dr. Arun, and we welcome you for the same. Over to you, Dr. Arun.
Good evening, dear colleagues. My friend Dr. Sneha, respected Dr. Ullas Patil, sir, Dr. Varsha Baste. As already Dr. Ullas Patil, sir, has said many things about Dr. Sneha and this academic activity. Sir has very nicely summed up everything, so I will not take much of your time. But I assure Dr. Sneha that Dhule, Nandurbar, Nasik, and Jalgaon people will definitely help you in your endeavor to become vice president of FOXI. And as we all know that Dr. Sneha has organized many webinars, and this has definitely helped to increase our knowledge. Being a teacher in medical college, mainly I am a teacher first, we still face the cases of PPH and medical emergencies, especially where unattended patients come to us, especially in medical colleges, and still we are facing the mortality because of PPH. Even though we talk much about the management of PPH, many advances in the treatment of PPH, still mothers are dying because of PPH. So it is high time that we and our juniors should think, actually we should think about why this PPH is occurring, and we should anticipate that how can we prevent such deaths. Because few days back only we had such a death of PPH in our medical college, where it became very difficult to explain to relatives also, and other what so-called karyakartas come with those relatives also. So this upgrading the knowledge of consultants as well as the students is very important, and all these academic activities are organized by the committee whose head is Dr. Sneha, and therefore to continue her endeavor in this, to upgrade the knowledge of all the friends, we must vote for her and we must see to it that she gets elected, so that these activities will be continued. I wish her best of luck, and I also thank Dr. Sneha for giving me this opportunity, and this opportunity to be the guest of honor for this webinar. I just came home from that meeting and I could attend this in time. So I am sorry that I joined it 2 or 3 minutes late, but I could just attend this time. Last time I could not attend, and many speakers in the panel and other experts, they are my close friends like Chandrakant Sankleta, Dr. Vilas Bole. A few are my students. So all are good panelists, and this will definitely be a knowledgeable session. I wish all the best to the panelists also. And once again, thank you for giving me this opportunity. Thank you.
Thank you so much, Dr. Arun, for sparing your valuable time and, of course, acknowledging all your friends and seniors. Thank you so much for your best wishes. And
thank you.
I definitely try to work for the cause and
yes.
make it work. Yes. Thank you so much.
Thank you.
Sahiti, may I have the CV of Dr. Varsha Baste, who is the fashionista, the style icon, the Raj Mata, whatever we can call her, but a very good human being, very simple, straightforward. I would not read her CV because all of you know the Vice President-elect of FOXY, of course, and she was a chairperson along with me for FOXY, International Academic Exchange Committee. So we would like to hear from you, Varsha. Over to you, dear.
Good evening, everybody, and so happy to be here. माहेरी आल्यासारखं वाटतंय, खानदेशचे सगळे लोक दिसतायत. So nice of you, Sneha, for inviting me and involving me in this very, very important emergency obstetric committee with Dhule, Nasik, Jalgaon, Malegaon, Chalisgaon, Nandurbar, all together with Dr. Vipin Pandit, Kiran, our beloved Dr. Rajendra Singh Pardeshi, Madhuri, and Sneha, you yourself. I'm so delighted. The standard of this webinar has been increased by the mere presence of Dr. Ullas Patil, who happened to be my classmate also, but he's such a phenomenal person. He has done so good work in medical field in Jalgaon and all over Maharashtra also. The students, PG, UG students and whatnot, medical health care, everything is provided by his center, and I'm really delighted and happy and to just by his presence here. And what should I say about Dr. Arun More? He is an academician and is such a stalwart in his field from Dhule Medical College and Dean also. And I'm really happy to be honored with him as a guest of honor. And what should I say about these speakers? My beloved friend, Dr. Mitra Saxena, wow. You have really chosen great speakers, Dr. Shashi and Dr. Mitra. They will deliver the best, because I have seen the workshops of Dr. Mitra Saxena for internal iliac ligation. She is much more sought after chairperson of this committee, and our chairperson, the chairperson for our speakers, Dr. Sangeeta Wagh, our president over here, and Dr. Narendra Zope. All of them I know very well. Dr. Vikas Bole is doing great work in Jalgaon, and Vinod Chaudhary, Dr. Shashi, and you are welcome to Khandesh. You must visit Nasik, and I have seen your deliver lecture, and you are very famous in North. Sneha has really grabbed you and put you in this great increasing the standard of this webinar. Sneha, you yourself are such a hardworking, such a nice, gentle fellow, and so hardworking. I have seen you catching flight coming from your Yavatmal to Nagpur and then catching flight, and never you grumble about whatever delays and whatever, because we were together for a long time. You are so meticulous and so sincere and so academically oriented, all the time working in the hospital, at the same time delivering lectures, and you have got great connect with the whole India faculties and Foxians also. Anjali Birur, the beautiful girl from Jalgaon, and our beloved Dr. Chandrakar Sankirecha is really learned person from Nasik. Panelists, I know each and everybody. Anjali is our secretary from NOJS, very active person. Dr. Vishal Patil, he is a really fantastic person from Dhule, very alert and very enthusiastic person. Sonali Ingle, my bro, Rajendra Bhatia, what should I say? All the Chopra people are dependent on him for emergencies, and perfect person for this as panelist for this webinar. Tushar Zamre, I know him very well. Also Sachin Khedkar, Monica Darling, I couldn't see her. Monica Singh, Anita Rajuri, and Varsha Lahade. All these three are so well deserved for their respective committee. We must give them due credit, and they should be, I will say, they should have been unopposed as chairperson, but still it is as an election. We will all we should all give them upper hand, and they should get elected. I wish all the best to all Sneha, Monica, Anita, and Varsha Lahade. And what should I say about convener? Monica Umbergad. She is such a girl. Without her presence, no webinar is complete in AMOGS. And Dr. Madan Kamble, coming from small society of Aklus, but he's so active. Revati Rane, Vandana, all have, I know them. Aklus, such a small society, but so active. So it doesn't matter how many people are there in one OBGYN society, but what is important is the heart of that society, which is pumping fast and actively doing all the activities. And I'm really happy to see all the conglomeration of all these great giants and stalwarts of Foxy. Really salute to you, Sneha. And I wish all you the best. And I'm really happy that you have involved me in this great webinar. Thank you so much.
Thank you so much, dear, for expressing all your emotions. You know, everybody has enjoyed your speech as guest of honor. Thank you so much for your gracious presence. Now I welcome, I think our AMOGS president and secretary, they're busy with some other, I think infertility work.
Parag Biniwale also joined.
Yes, Dr. Parag, our ICMG chairperson elect, and the AMOGS national coordinator and a very dear friend of mine has joined for, wishing us, and of course, joined for this program. So I welcome Parag and to say a few words from your side.
Oh, thank you, Sneha. I'm just intruding the guest of honor, but it's pleasure to share virtual dais with Dr. Ullas Patil. I'm seeing Dr. Ullas after such a long time, and I have fond memories of visiting his then small hospital way back in 1990. I hope you remember that. And in fact, we spent an entire day. We had spent an entire day with Dr. Ullas Patil, and of course, my dearest friend and classmate, Dr. Arun More, who's sitting here, and all the dignitaries. Thank you, Sneha, for asking me to join. It's indeed a pleasure to be talking to the societies. Two of the societies I've visited, but I'm looking forward to visiting Jalgaon because that happens to be my birthplace. So I'm sure Dr. Bode is listening, and I'll definitely come down sometime.
Dr. Patil joined.
Today's program is very interesting. You have chosen very nice speakers. Dr. Mitra Saxena, who's the chair of the Practical Obstetrics Committee, and Dr. Shashi, who's an expert in PPH, and of course the panel discussion which you are going to moderate. So I'm sure it's going to be a great learning experience for all of us. And Sneha, my best wishes for your forthcoming elections. I'm sure everybody sitting here and listening to the webinar would ensure that you occupy the chair which we want you to see. Thank you very much for the invite.
Thank you so much, Parag. Thank you so much for your best wishes as well. I welcome Dr. Rajendra Singh Pardesi, the immediate past president of AMOGS, who is also my mentor in AMOGS and FOXY. So we would like to listen to your precious words, sir. Sir has just joined from emergency, he has come back. So over to you, sir.
Good evening. Good evening, everybody. Respected Chief Guest, Dr. Ullas Patil, sir. Guest of honor, Dr. Arun More, Dr. Varsha Baste.
Namaskar,
And
sir.
I'm very much proud and honored to be a part of this program with my hometown and home area. Jalgaon is my hometown. Remember, still I am residing in Bhargaon district. All relatives are in Jalgaon, Dhule, and Nasik only. So, and all other dignitaries, Dr. Mitra Saxena, Dr. Vilas Bole, Dr. Sheetal, Dr. Parag Biniwale, Dr. Shashi Kabra, and our AMOGS chairpersons, Dr. Varsha Lahade, and Dr. Madan Kamble, Dr. Monica Ubardand. So, I wish to congratulate Dr. Sneha Buyar, and she is contributing a lot to reduce maternal mortality, as this topic is concerned with PPH and all that. PPH is major cause of maternal mortality, as Parag also told. Nice topics are chosen for that. So I think this will be a great event with the active participation of the excellent, eminent faculties and speakers. So I wish every success to Dr. Sneha Buyar for her future endeavor in FOXY as Vice President FOXY in forthcoming elections, and also to Varsha Lahade for her future endeavor in FOXY as Chairperson of MTP Committee, and to Dr. Anita Rajoria also for her future endeavor in FOXY as Environmental Chairperson of Environment.
Thank you, sir.
And also to Monica Singh for her future endeavor in FOXY as Chairperson of Perinatology Committee. So wishing every success to this webinar. Thank you. Thank you so much for inviting me. Thank you.
Thank you, sir. Thank you so much. So after the blessings of God Almighty and the blessings of our respected Chief Guest, Dr. Ullas Patil, sir, and guest of honor, Dr. Varsha Baste and Dr. Arun More, of course, my mentors in AMOGS, Dr. Rajendra Singh Pardesi and dear friend, Dr. Parag Biniwale. I thank everybody for gracing this occasion, and I thank all the speakers once again, Dr. Mitra Saxena and Dr. Shashi Kabra, the chairpersons, also Dr. Sangeeta Wagh and Dr. Narendra Zope, also Dr. Vilas Bore and Vinod Chaudhary, Dr. Anjali Bhirud and Dr. Chandrakant Sanklecha as the panel expert along with me, and my esteemed panelists, Dr. Anjali Kulkarni, Dr. Vishal Patil, Dr. Sonal Ingre, Dr. Rajendra Bhatia, Dr. Tushar Zamre, Dr. Sachin Khedkar, Dr. Monica Singh, Dr. Anita Rajoria, Dr. Varsha Lahade, and of course, my right and left, Dr. Monica Ubardand and Dr. Madan Kamble, who have been working very hard for me throughout the last 2 years, I would say. And I thank all of you for gracing the occasion. And I declare that the inauguration is done. And without much ado, I would request Monica to go ahead with the academic session. I'm sure it will help the attendees very much. Thank you so much.
Thank you so much, ma'am.
I thank all of you for, blessing me with all your wishes and also the best wishes and all your support. So thank you so much.
All the best, Neha.
Thank you so much.
Thank you, ma'am, for giving me an opportunity to coordinate this webinar. I now declare that the inauguration is formally over, and I thank Dr. Ullas Patil, sir, Dr. Arun More, sir, Dr. Varsha Baste, madam, Pardeshi, sir, and Parag, sir, for joining us and gracing the occasion. We move forward for the first session, that is medical management of postpartum hemorrhage by none other than Dr. Mitra Saxena Madam. Our chairpersons for today's session, Dr. Sangeeta Wagh Madam. She is a director and consultant of Usha Hospital and Maternity Home Nashik. She is also the executive committee member IMA Nashik, the past secretary of Nashik OBGY Society and current president of the same. She is also the editor of Souvenir AMOGS Nashik 2023 and has been practicing since 1997. Her areas of interest are high-risk pregnancy, maternal health awareness, and maternal mortality. We welcome you, ma'am. Our next chairperson for today, Dr. Narendra Zope sir, has completed his MBBS from GMC Dhule and MD from GMC Nagpur. He is also had an ICMR genetic course from SGPGI Lucknow. We welcome you, sir, as a chairperson for the session. I request Sangeeta ma'am to please introduce Dr. Mitra Saxena ma'am.
Good evening to all. Good evening to all respected dignitaries. Good evening, Sneha madam. Good evening, Ullas Patil sir, अरुण मोरे सर. मला तर एकदम माहेरी आल्यासारखंच वाटतंय, कारण जळगाव, धुळे, नंदुरबार आणि मी जळगावचीच आहे आणि मला उल्हास पाटील सरांमुळेच गायनेकमध्ये इंटरेस्ट निर्माण झालेला आहे. आणि मी गायनेकोलॉजिस्ट बनण्यामागे सरांचाच खूप मोठा हात आहे, उल्हास पाटील सरांचा. Without wasting the time, I will introduce our eminent speaker for the today, Dr. Mitra Saxena. Madam was a chairperson for Practical Obstetric Committee FOXY in 2021-24. She is a convener and project director for Mukta Gynec. She is a senior consultant of OBGY and also in the private practice in Rewari, Haryana. She is an active member of FOXY since last 20 years. She is a past president and now patron of Rewari Obstetrics and Gynecological Society to increase awareness about freedom from unwanted pregnancy, also breast cancers and awareness, and also cervical cancer free India amongst doctors and women of Haryana. So she is a very dynamic lady. Over to you, madam. Thank you.
Thank you very, very much. At the outset, I would like to extend my, heartfelt thanks to dear friend Sneha. Along with that, I would also like to wish you, Sneha, all the best. All your sincere efforts should bring you home comfortably as our vice president. It's indeed an honor for me to be included in this AMOGS program, where I am going to be speaking in the presence of senior obstetricians, our chief guest, Dr. Ullas Patil, guest of honor, Dr. Arun More, my very dear friend, Dr. Varsha Baste, our lovely, mentors, Dr. Parag Biniwala and Dr. Rajendra Singh, all my chairpersons, Dr. Sangeeta and Dr. Narendra. I'm really, happy and thankful to you, Sneha, to think about me as the speaker for today's topic on medical management of PPH. With your permission, I would like to take off, and please do not hesitate in telling me when my time is going to be up. So friends, are you able to see my screen?
Yes.
Am I audio visible
Yes.
and audible?
Yes, Mitra, go ahead. No
Okay,
problem.
so we all know that PPH is a story of blood loss, maternal jeopardy, sacrifice of uterus, and obstetrician's nightmare without thanks, very high possibility of litigation, heartaches for all of us. But on a fateful day, medicines actually save us, help us save the life. So we are going to be talking about the medical management of PPH. We all know the definition of PPH, and when we consider it in the terms of amount of blood loss, the definition stand at 500 ml, more than that, regardless of delivery, or, after normal delivery, more than 500, after cesarean, more than 1,000. So within 24 hours, primary PPH is that amount of blood loss. But also it is important to remember, if there is a change in the hematocrit or any amount of blood loss, that can make our patient hemodynamically unstable. Secondary PPH, on the other hand, is hemorrhage evident after 24 hours of delivery, up to 3 months following delivery. So we all know that it is the commonest cause of maternal death, and it is a cause of concern for all the associations, WHO, FIGO. And so the content of my talk today has been taken from FIGO, WHO and my dear friend, Dr. Poonam Goel. And I would like to share that despite all the efforts that are being put together, we know that 3% of all vaginal deliveries, even with appropriate management, may still die. With a global incidence of 11%, 40% die at level 1 facilities, clinics, district hospitals, and 50% of maternal deaths occur within 24 hours. We know that very recently a gynecologist herself in Tamil Nadu lost her life to PPH. So we all know that at term, the amount of blood flow to uterus is extremely high, around 800 ml per minute. So within 10 minutes, if the arrest of hemorrhage doesn't happen, a patient can easily die. And we know PPH is the fastest killer, killing within 2 hours. Now, it is preventable provided this standardized and multidisciplinary programs are implemented. At Foxy level, our aim is to spread this information that if all the maneuvers are done properly, timely, and in a very disciplined way, we are going to be able to bring down the maternal loss, maternal near miss. And most importantly, it is failure to recognize excessive blood loss and amount of, estimate exact amount of blood loss. Instead of starting immediate resuscitation, there are sometimes delays, inadvertent delays. And we know that too little, too late is one of the most important reasons for losing women to PPH. Now, what are the challenges in managing PPH is, most important is estimation of the blood loss. And the second is how and what to use, what intervention to be done to manage PPH. So, friends, our aim in managing a patient immediately after delivery centers on being very alert about the blood loss, not just the consultant or the team, leader, but also the support staff. That is why training of our nurses, our midwives, our residents is extremely, extremely important. And I hope that today's lecture, the whole session, that means the medical and the surgical management of PPH, will help, elevate our readiness and, a revision of all the drugs and all the interventions that should be taken up timely. So it's what is important is to understand that you cannot just keep waiting. You've given something and you wait. You have to be very alert. So at the end of my presentation, I'll be presenting the pin-up girl, which is so very important, how to organize the team. And you all know that my committee, all the dedicated members of the committee have really put their hearts and minds together to organize drills. And PPH drill is one exercise in which we can get the whole team ready to deal with this emergency. Now, priority, of course, is to stop the bleeding before patient develops dilutional coagulopathy and organ damage from underperfusion. And after having exhausted our conservative approaches, we have to move on to the invasive or the surgical procedures timely. This is the essence of saving the patients. So, let us not let the patient go from compensated stage to decompensated stage. So obviously, the most important thing is prevention and management. So we all know that, making sure that our women do not enter delivery with anemia, that is one of the most important preventive aspects. Now, we all are much aware of all the bundle approach, the emotive trial and all. So basically, all the procedures that we've been doing all along in managing a patient who has just delivered is just putting these whole things together in a perspective so that we do not miss anything. So emotive is a mnemonic which every alphabet spells one intervention, which is very important. So just look at it as, first thing is detection of hemorrhage. So E is early detection, M is massage. All of us know that the most important reason for PPH is atony. So a massage of uterus ensures that the tone of the uterus is felt by the hands of the obstetrician, and also if it is not tight, then we know what should be the next step, and that is to use the oxytocics, the tranexamic acid, timely supplementing the crystalloids, and E is examination and escalation, meaning to say ruling out the other causes for PPH, that is the traumatic PPH, and whatever procedure may be needed next has to be in mind. Now, we all know that these are the common 4 reasons for PPH: tone, thrombin, trauma, and tissue. And tone contributes to 70%. So imagine how very, very important it is that the management of PPH actually centers on efficient, arrest of hemorrhage from the living ligatures. We all know that oxytocin has stood the test of time as a drug for prevention as well as management of PPH. Now, we all know that this is one place where nature is at its best. So if the living ligature, that means if the uterine tone is good, majority times we will not be subjected to atony. So in case the uterine tone is poor, for example, in a patient of severe anemia or over-distended uterus, as in a big baby, grand multi twins, or induced labor, there we need the use of oxytocic agents, or those agents which work on the uterine tone, known as uterotonics, to ensure that the uterus contracts efficiently and arrests the hemorrhage. So now we all have to understand that prevention is better than cure. So active management of 3rd stage of labor, one cannot, not mention that prevention, this is the most important thing is, and that is using oxytocic to prevent PPH after the delivery of the baby. And we all know that WHO, FOXY, FIGO, all associations have recommended the use of oxytocin after the 3rd stage. And if oxytocin is not available, what are the options? All the uterotonics can be used in the dosages already mentioned to ensure that the uterus retracts and there is no PPH. Now, what are uterotonics? All the, pharmacological agents which produce strong contraction of the uterus are called as uterotonics. So, oxytocin, ergot alkaloids, misoprostol, carbetocin, and carboprost. They are all these medicines are basically those which act on the uterus throughout the pregnancy, and their use is prohibited in the early part, and it is always the use for managing PPH. Now, let us look at what are the FIGO recommendations for managing PPH. As I said, that uterotonics, that means the oxytocin, the ergometrine, the injectable prostaglandins, misoprostol, these are the drugs which are used to manage PPH. Of course, the preventive management, that is the active management, is by IM oxytocin after the delivery of the baby, or we can even use misoprostol, especially when oxytocin cold chain is not maintained. Now, what is the role of carbetocin? We all know that carbetocin is the new drug on the block, but carbetocin presently in our country and by FIGO, it is only placed as managing the active management of the 3rd stage of labor. And although it's a very, very good uterotonic, but it has not yet been included in general guidelines of FOXY as a drug for managing PPH, atonic PPH. So, the charm to revise the whole pharmacology is intense, and we all know what is oxytocin. So quickly, I will just say it is an extract from posterior pituitary. What we are using is a synthetic metabolite, and it causes rhythmic contractions of upper myometral segment, ensuring that the blood flow is arrested. What is important to remember about oxytocin is that it is effective intravenously or intramuscularly. Now, already, as I mentioned, an emotive trial, this is for prevention. Of course, this is for the management of PPH, that once there is atony, IV oxytocin 10 units slowly can be given, or it can be infused in 200 to 500 ml crystalloids over a period of 10 minutes. Once, we are continuing to do things simultaneously, as I said in the very beginning, that there is a hand inside the uterus which is massaging to make sure that the uterus is, contracting, the tone is good, and side by side, this is the first uterotonic of choice. And along with this, if the tone is not yet recovered, we add 20 units in 1000 ml saline to be administered over 4-hour period, with or without misoprostol. So basically, this slide actually sums up the important uterotonics that are used to manage the PPH. Now, there are adverse effects of oxytocin. If a big IV bolus is given, it causes severe hypotension. So it's preferable that oxytocin is put in the crystalloid 500 ml of ringer lactate and given slowly. And to maintain contractility over 4 hours, oxytocin is carried on. We have to understand that there'll be side effects of any medication, and these are the things which one has to remember, that it can cause, especially the IV bolus, can cause this hypotension. Also, we have to remember that when oxytocin is being used, it can cause more complications. One of the reasons for the traumatic PPH could be indiscriminate use of oxytocin. So all these things have to be kept in mind when we are using this drug called oxytocin, which has a very short half-life. This is the good thing, that it produces its effect very quickly. It is effective immediately within few seconds, in a minute. And important thing is that oxytocin needs to be refrigerated so that the cold chain is maintained. If continuously you have a spate of patients who are having atony, then I'm sure it's time to see whether the cold chain is being maintained or not. So onset of action is within 1 minute and lasts only for 5 minutes. So that is why continuous infusion is important. Now, the side effects of the oxytocin is related to the dose and the rate and the route of administration. The other medicine which is available, which is cheap and very effective, is misoprostol, prostaglandin E1 synthetic analog. This is again extremely effective, and it can be administered orally, sublingually, buccally, perrectally, or pervaginally. And the onset of action is pretty rapid, within 10 to 15 minutes, all except rectal route, which is slower, and it is preferable to use perrectally. Half-life is 20 to 40 minutes, and FIGO and WHO recommend 600 microgram orally or perrectally if injectable uterotonics are not available. No, there are side effects of misoprostol. It is commonly, it produces shivering and chills and fever, diarrhea, abdominal pain, hypothermia, and all of us who are using misoprostol know that we have to be alert when misoprostol is being used. Let us look at this time-tested pharmacological agent, ergot alkaloids, ergometrine. Again, this is heat sensitive. That means it has to be stored in the refrigerator. They are serotonergic receptor agonists, and they work effectively on the upper and the lower segment, and the onset of action is rapid and the duration of action is longer. The good thing about ergometrine or methergine is that it produces effective contraction, restoration of tone of uterus, but then it also increases the blood pressure. So it is contraindicated in cases where there is high blood pressure or there is cardiac problem with the mother. We do not want immediate increase in the maternal vascular compartment and precipitation of heart failures. So again, this can be given intravenously, intramuscularly, or intramyometrally, and its vasoconstrictive effect is extremely effective. So it has its good points as well as its contraindications in patients of hypertension and Raynaud's and heart disease. So this is a one thing is that even if you're having oxytocin, carbetocin, it's very, very important that your labor room should be well equipped with methogen injections and with especially the temperature maintenance is important. Now, this has side effects, again, nausea, vomiting, and increase in blood pressure. So this has to be kept in mind when we are using methogen. Coming to carbetocin. Now, we all know carbetocin is the synthetic, long-acting analog of oxytocin. So the good thing is that it actually works just like oxytocin, and the action is, immediate, and the effect is sustained. This is the way it is important and different from oxytocin. Presently, after the Champions trial, a lot of centers in India have been a part to this trial, that carbetocin is approved as an active management third stage of labor drug, not yet included in the armamentarium to manage PPH, although some of the guidelines, especially the Canadian guidelines and the Australian guidelines, New Zealand guidelines, have included it as a drug for PPH management. When I say this, it is a lot of our colleagues have started using it as active management. Even I have kind of classified in my patients all those patients who are high risk for PPH. For example, those who have had prolonged labor, induced labor, big babies, patient is in labor for a long time, membranes are absent, or it's multiparity, big babies. There I use carbetocin instead of oxytocin for active management of third stage of labor. And honest to goodness, our incidence of atonic PPH has remarkably decreased. We're still waiting that carbetocin should be included as a therapeutic intervention for managing PPH, not just active management, but management of PPH. I hope I have made this distinction clear that presently in our country, carbetocin is only being used as active management third stage of labor drug and not yet managing as PPH for managing atony. Although there are a lot of places where carbetocin comes out better than oxytocin, especially because its duration of action is longer. But also it is important to remember that they have the same receptors. So if you have used one, you may not be successful in using carbetocin, where oxytocin is already being used as for active management of third stage of labor. These things have to be kept in mind. And the good thing about carbetocin is that it produces rhythmic contractions. Its onset of action is within 2 minutes, lasting for about 6 minutes, and the effect is sustained for around 40 to 60 minutes. So its half-life is more than that of oxytocin, which is only for 4 to 6 minutes. So this is very important thing to remember, that oxytocin needs to be refrigerated, whereas carbetocin is heat stable. Now, this is what I was mentioning about the Champion trial, of which our country has also been part, where this molecule has been tested and found extremely successful in controlling PPH in patients of by using it as an active management of third stage of labor. So remember, Champion trial just ensures that carbetocin is included as a preventive medicine, not yet as the medical management of atonic PPH. So coming to although, when we look at all the good points, we feel that carbetocin should be, included in our armamentarium also to manage PPA. Now, coming to one very important drug, that is the tranexamic acid, the T of the E-motive trial. So E for early detection, M for massage, O for oxytocin, and T for tranexamic acid and IV fluids. Now, tranexamic acid, as we all know, is an antifibrinolytic drug which is useful for both prevention and treatment of bleeding in various clinical settings. And there is a lot of, trials on its prophylactic use as well as its use in the management of PPH. So it gives me great happiness to share that tranexamic acid is now included as a treatment for PPH. So whenever we are dealing with PPH, within 3 hours of delivery of the baby, one should use tranexamic acid 1 gram over a period of minute intravenously. Now, this is important that it can be repeated, but beyond 3 hours, it will have no, useful effect. So the side effects of tranexamic acids are more of theoretical concerns, and it is extremely useful, and now it has been included by FIGO and in the E-motive trial. So FIGO, it does not recommend use of tranexamic acid prophylactically, but as soon as the diagnosis of PPH is made within 3 hours postpartum, this has to be included. So when we talk about medical management of PPH, then again the time-tested medicines, that is the oxytocin, ergometrine, misoprostol, and carbaprost and tranexamic acid is the list which will be complete when we are thinking about how to manage medical management of the PPH. Now, this is a very important image, and I'm sure everybody who's dealing with deliveries and PPH will have put this up in their labor rooms. So basically, this has been supplied by National Health Mission. Pin girl means the head end has, everybody is positioned so appropriately so that they can manage this complication called as PPH, whether it is PPH or eclampsia or any shoulder dystocia. This is how it should be stationed so that a person who is at the head end can look at the general consciousness of the patient, breathing, give oxygen, give misoprostol, and keep on reassuring the patient, because the patient is not unconscious and she is quite panicky when she is losing blood. So then the patient or the person on the right side or the arm's end checks the vitals, is there to put the IV line, to take out the samples, and to start the fluid resuscitation, and or if aortic compression as a temporizing method is needed, then that person is most suitably placed to put the pressure on the aorta from the right side. And at the perineal end is the main obstetrician or the senior obstetrician who arrives there if the delivery has been conducted by some junior, massaging the uterus, doing the bimanual compression of the uterus, and coordinating and giving out the orders, asking for instruments so that the traumatic PPH can be ruled out, and all the etiological factors, that means the atony, trauma, evacuation of the uterus, all can be performed in the single sitting. So it's not one after the other, it is all simultaneously. Things have to be done, and an eye has to be kept on the vitals so that we have the idea whether the patient is improving or deteriorating, and we need to escalate our management, go for compression, go for tamponade, or take the patient to the OT and do the surgical management. So this is a summary of emotive trial. I mean, actually, whenever we are dealing with PPH, this is how we should organize our whole team. और अकेला व्यक्ति कभी कुछ नहीं कर सकता. We always win a match if we work as a team. So this slide, friends, if anybody would like to take a picture, this kind of summarizes the dosages and how all these pharmacological drugs should be used. Oxytocin, 10 to 40 units in 500 to 1000 ml of normal saline to be infused. So the idea is that the uterus is kept contracted over the next 4 hours, whether this is after cesarean section or after normal vaginal delivery. Again, tranexamic acid is now recommended as a modality to manage atonic PPH. So 1 gram infused over 10 to 20 minutes. And if bleeding persists, it can be repeated within second dose can be repeated, but not beyond that. Now, we all know how ergot alkalides, methyl ergonovine can be given 0.2 milligram IM every 2 to 4 hours, or IV or IM and maximum 4 doses. So we all have to understand what is the upper limit. Carboprost is to be given 0.25 microgram IM every 15 to 90 minutes up to 8 doses, which is the maximum dose. So it can be given intramuscularly or intramyometrally. Never ever this drug can be given by any other modality. We know mesoprost is heat stable to be given rectally, and dinoproston again can be given vaginally or rectally. And recombinant factor, human factor 7. Now we all know that this is a extremely good agent in our hands. I'm sorry, it just slipped my mind. I should have included the recombinant factor because now it's very much available, and it is very nicely to be placed before we take up for the surgical interventions. And we do hope that the understanding of recombinant and use of recombinant factor can be popularized, provided the pricing comes down. Now, these are the surgical interventions, and I'm sure Dr. Shashi will take us through. And thank you very much. I hope I have not extended my time, and I've tried to cover up the topic. Sorry, I should have taken recombinant factor 7, but maybe that topic itself needs a lot of explaining because it's a new drug, and it holds a lot of promise because it actually works on the coagulation cascade. So imagine how effective it is to arrest hemorrhage, and this is only because it is extremely expensive that it is not right now in our radar, but those who can afford it and those who have used it have actually spoken very highly about recombinant factor 7 as well. Thank you, Dr. Sneha. I hope I've stuck to my time and I've done justice.
Yes, I think, thank you so much, Mitra. You have done well. And thanks for making it in time. Definitely, we would invite comments from the chairperson, and I think we will have the question answer session later. Thank you. Over to you, chairpersons.
Thank you, Mitra Madam, for the excellent lecture covering all the points in the medical management, and definitely it is very important. And the recent factors also you mentioned, but regarding the cost, it is not on our radar. Thank you for very nicely covering all the points. And thank you, Sneha Madam, for giving me this opportunity as a chairperson among the stalwarts. And we all know the credentials of Dr. Sneha Madam. आपण त्यांना खूप दिवसापासून ओळखतो आहे. त्यांचे बाकीचे सगळेच आपल्याला माहिती आहे. विश यू ऑल द बेस्ट, मॅडम. I support all from my Nasik OBGY society, wholehearted support to you. And my neighboring society, Dhure, Jalgaon, Nandurban, all are with you, madam. Wish you all the best. And thank you for arranging webinar on such an important topic. And I thank our convener, Dr. Madan and Dr. Monica, for arranging the webinar. And thank you all.
Thank you. Dr. Vilas, any other comment from the chairperson? You can unmute yourself.
Hello, am I audible, ma'am?
Yes, yes, Dr. Vilas, go ahead.
It was very informative talk by Dr. Mitra, madam. But I am eagerly waiting for the surgical part of this because I am very much interested in that only.
I just want to say one thing that interestingly, we think that we know all these medicines, but when we are confronted with atonic PPH, then suddenly everything, becomes a muddle. How many times can we repeat methergine? At what frequency should we give carboprost? And so that is why it is very important. And because majority times it is atony, and if we use these medicines judiciously, we'll be able to control PPH. And hopefully the surgical interventions which are going to come next, which are very thrilling, as Dr. Vilas has rightly mentioned, but then lesser often we need the surgical interventions, hopefully, and we should be able to manage PPH with the medical management. Thank you, Dr. Sneha, and I wish you all the best. You are so hardworking, and all our aspirants today. I'm happy to see Dr. Anita, Dr. Monica, and Dr. Varsha also along with you. So best of luck to all of you.
Thanks,
Foxy is
ma'am.
always richer with presence of such dynamic people who are so committed to take the torch of academics, awareness, everything. It's a pleasure to have been associated with you. And thank you that you've brought me closer to the societies of Nasik, Jalgaon, and sorry,
Societies of Maharashtra, you can say.
all Maharashtra.
Mm.
Yeah, you all are
Right.
so loving, and thank you so much.
Thank you, dear. Thank
मेरा
you.
revision हो गया. Thank you, Suneha.
Thank you, ma'am. Thank you, Mitra ma'am, and thank you, Sangeeta ma'am. Thank you, Zope sir, for chairing the session. We move on to the next part of our session, that is surgical management of postpartum hemorrhage by Dr. Sashi Kapra madam. Our chairpersons for this session are Dr. Vikas Bhole sir. He is the director of Matrushaya Hospital, Jalgaon, the ex-joint secretary IMA Jalgaon, ex-chairperson IMA AMS Jalgaon chapter, ex-secretary IMA Jalgaon, ex-committee member PCP NDT, ex-committee member PCP NDT Jalgaon City. He is also the ex-member delegation to Kolhapur PCP NDT as silent observer. The ex-clinical secretary of Jalgaon. He is currently the president of Jalgaon OBGY Society and the vice president of IMA Maharashtra State, and he has many awards to his credit. We welcome you, sir.
Thank you.
Dr. Vinod Chaudhary, sir, has done his MBBS from KA Mumbai and DGO from Kalwa Thane. He is practicing since last 15 years. He has been a Maji Nagar Sevak, and he is the vice president of Jalgaon OBGY Society. We welcome you, sir, too. I request Vilas, sir, to please introduce our speaker for today.
Good evening, everybody. Good evening, Sneha madam and the team. It was very nice to hear from many of us that they are related to Jalgaon directly or indirectly. Namaskar, Arun More sir, माझे UG teacher. As Sangeeta said in previous talk, that she was inspired to become a gynecologist from Dr. Ullas Patil sir. The same thing is with me, senior gynecologist from our hometown, Dr. Ullas Patil sir, and my UG teacher, Dr. Arun More sir. These two people were inspiration for me to become a gynecologist. Now, I would like to welcome the speaker, Dr. Shashi Kabra madam. And Dr. Shashi Kabra madam, by any chance, you are also related to Jalgaon, because we have many Kabra and Maheshwaris in Khandesh, Jalgaon also.
Sir, we have many Maheshwari relatives in Jalgaon.
Okay. Thank you, ma'am. So, Dr. Shashi Kabra ma'am, of course, she is a senior OBGY specialist from Delhi. She has got many awards in IMA Precision Award, then recipient of Wonder Foxy Award, APJ Abdul Kalam Appreciation Award, IMA WDW Karmavir Award, Champion Award Obstetric Critical Care 2021, APJ Abdul Kalam Excellence Award in 2022, DDU Hospital Best Doctor Award 22, Pride of North India Gynec Forum Award 2023, Mentor Lakshya Government of India, Member Practical Obstetric Committee Foxy, then North Zone Coordinator Medical Education Committee Foxy. She has organized 85 workshops on PPH all over India, and I am very much eager to listen her regarding the surgical management of PPH, what date we may land up into such disaster sometime. She's also associate of the prestigious RCOG, and patent. She has got patent of right of teaching model on IIL. So I welcome you, ma'am, and over to you.
Thank you so much, sir, for such a kind introduction. My sincere thanks to Dr. Sneha Bhuiar, ma'am, and the societies of Dhule, Nasik, Malegaon, Jalgaon, Chalisgaon, Nandurbar for organizing this webinar. My special thanks to Dr. Ullas Patil, sir, Dr. Varsha Batse, ma'am, Dr. Arun More, sir, and the conveners, Dr. Monica, ma'am, and Dr. Madan Kamle, sir, for giving me this opportunity. So is my slide visible?
Yes, Shashi, go
Yeah.
ahead.
So I'm talking about surgical management of postpartum hemorrhage. And my first slide shows that it will convert your nightmare into an expertise. If you learn this skill, then you will become an expert. It will no more be a nightmare. And I always say, whenever I give a talk on this particular topic, I always say there should be no word like panic in the dictionary of a trained obstetrician. The great Anglo sir said, while managing postpartum hemorrhage, time lapsed should not be counted in a minute. One has not lost 1 minute, but 60 seconds. So each and every second is important in managing postpartum hemorrhage. A patient of postpartum hemorrhage may die in 30 minutes if left untreated because the uterine artery blood flow is around 600 to 800 ml per minute. And it is a preventable cause of maternal mortality. So we should leave no stone unturned to prevent this death. There is some. So when medical management ends, then we start with surgical management. And these are the balloons. Balloons were previously classified into surgical management, but now by FIGO 2022 guideline, they are called the mechanical or non-surgical management. So you can see here the condom balloon, our own Chhattisgarh balloon and Bakri balloon. Now their mechanism of action is same. The intrauterine pressure increases more than the systolic blood pressure and prevents bleeding. And this is the balloon which I have designed recently and filed a patent for this. This is an intrauterine balloon. It looks like a Bakri balloon, but this is very sturdy and there is no drainage port in this balloon and this end is not pointed. So when it gets inflated, then it takes the shape of the uterus only. And these are the locally available things, one 3-way cannula, one drip set, one syringe, and one Ringer's lactate to normal saline, which is available everywhere. I made this balloon with all locally available things. And when I attach a 3-way cannula here and hang a drip set with drip bottle, and then from one side, we withdraw fluid, and then from other side, after changing the direction of the 3-way cannula, we push Ringer's lactate or normal saline in the balloon. Very quick and very good. And it is not friable like a condom balloon. It is very sturdy and it shall be available in ETO sterilized pack. And remember, the cost of Bakri balloon varies from 7,000 to 14,000 in different parts of the world, and it will cost less than 1,500. Means it meant for every poor woman of India. So these are the options for surgical management. Before starting on this, I would like to mention that there are few conservative methods and some radical methods. So these conservative methods, we apply them only when the patient is hemodynamically stable. Patient has not gone into shock. Her systolic blood pressure has not gone down anytime. Only then we will use these conservative measures. But once the patient has gone into shock, her shock index has gone more than 1, 1.2, 1.3, then the role of conservative surgery decreases and we are left with only resort medical surgery. And remember one thing, perform hysterectomy sooner rather than later. So we have these methods, B-Lynch, then uterine artery ligation and ovarian uterine artery ligation and internal iliac artery ligation. So first coming to uterine compression sutures, we have to rule out traumatic PPH and they are performed when the patient is hemodynamically stable. So over the years, when Mr. B-Lynch first described these sutures, he used number 2 catgut or number 1 catgut. Later on, he shifted to Vicryl, which is polygalactic 910. And now he's also using monocryl, which is polyglycaprol. And the suture length, everywhere you see, it is 75 to 100 centimeter, because in one go, we have to take suture around all the uterus. And the needle should be a 70 mm needle and it has to be round body. If it is a cutting needle, then it will pierce uterine musculature and will cause bleeding. It's a very good chart. I made it myself. So those who want to take a screenshot can take for this. Now I'm only showing you the practical things. So starting my video on B-Lynch sutures, this is a model of uterus, woolen model of uterus. Just let me know I request the chairperson to let me know that it is audible.
This is the ending.
Is it audible, sir? This is the anterior side of the uterus showing the LSCS incision, upper flap, lower flap. This is the cervix, and this is the posterior side. Now, before applying bleeding sutures, we have to confirm whether the suture will work or not. So, we have to exteriorize the uterus, put one hand on the posterior side, one on anterior side. We have to compress like this, and we have to see if the bleeding is reduced. If bleeding is reduced after applying this pressure, then we can presume that this suture will work, and we can proceed with these sutures. To identify few points, on the anterior side, this is the LSCS scar. There is point A, 3 cm below the lower incision and 3 to 4 cm medial to the lateral side. Then we have point B, 3 cm above the upper part of the incision and 3 to 4 cm medial to the lateral side. And similarly, we have point E and F on the opposite side. And we move the uterus posteriorly. Then we have point C, which is just behind the location of point E and point A and B. And we have point D, which is just behind the location of point E and F. And they represent the site of insertion of the uterosacral ligament. Now proceeding with the sutures. This is point A, 3 cm below the lower flap. I am going from outside to inside at the lower flap and enter the uterine
100 centimeter suture. That I am using.
Then from inside to outside, I am coming out through point B, which is 3 cm above the upper uterine flap. Now my assistant will help me, and I will curl around the fundus. This distance is 4 cm medial to the uterine column. Hold it like this. This is point C. Now I will pierce from point C and will come out anteriorly in the uterine cavity.
I am coming out in the uterine cavity.
Now I am inside the uterine cavity. Again I will pierce through point D and will come outside. So this is the location of point D.
Again from the uterine cavity to posterior side at the level of point D.
Posteriorly. Assistant will again help and will keep on compressing the uterus. Now I will enter the uterine cavity again through point E. And will come out again through point F.
So with one long thread, I have taken all the sutures.
Assistant will throughout keep the uterus compressed, and now we hold it. Then the uterine incision suture is to be closed, and we have to take utmost care of the angles.
You have to close the uterine incision. And now I will tie the sutures. Look at the knot.
Now I will tie the sutures. Keep it compressed.
Double turn in the first knot.
First turn, second turn.
Make the knot
This is
square.
tying of the knot, and it is to be closed. This is second suture, and this is third suture. So it will look like this, and we can cut it. So this is how the billing suture will look anteriorly, and this is how the billing suture will look posteriorly. Uterus is exteriorized.
Am I audible? This video sound is audible?
Yes, yes.
Yes.
Yeah.
Not the new ones. No.
So now I will show you the chose suture. This is also another type of compression suture only. I tell you one thing about the methodology of compression sutures. Actually, they are given through and through the muscle part of the uterus, and the purpose is to occlude the lumen of the spiral arteries, which is responsible for the postpartum hemorrhage. So, Cho suture are usually given in the fundus of the uterus, just below the fundus of the uterus in the body of the uterus, and it is applied in the localized area of bleeding. We can apply multiple Cho sutures also. So now my assistant is holding the uterus. This is the anterior side of the uterus, and I am showing you the Cho suture. For this, we have to take a straight needle because it has to pass through both the walls of the upper thick segment of the uterus. This is catgut. So suppose I am applying a Cho suture here. So I will pierce through here and I will come out on the posterior wall. That's why the needle, long straight needle is required. Then I am piercing it posteriorly like this and coming out anteriorly. Again I will go to the posterior side and coming out anteriorly. And again I will come out anteriorly by piercing from the posterior side. So just have a look. From anterior side it is looking like this, and from the posterior side it is looking like this. Now its assistant will hold the uterus and I will just tie the suture.
Two turns in the first knot.
Make the knot square. Make the knot square. It is done like this. Assistant will keep compressing the uterus. Second knot and the third knot. Similarly, we can apply one more Cho suture like here, like this. Then piercing here and coming out, just a minute, here. Again entering from the posterior side, from anterior to posterior like this.
In a case of
and again coming anteriorly.
I applied Cho suture on the vaginal wall and that responded very nicely. So I think this is clear
and then
how it is applied. I think this is Hemant suture.
Uterus is exteriorized and I will pierce the needle through the.
In Hemant suture, we don't have LSCS scar.
C. This is point C.
So it is directly pierced, not going into the cavity.
And hold it like this.
So this is Hemant, very simple suture.
Keep compressing the uterus.
Especially when the patient's abdomen is open for surgical management and she had a vaginal delivery.
That is what is the advantage for this suture. You don't have to open the uterus again.
Yeah, exactly. Very quick, hardly takes 30 seconds to 1 minute. This distance from Konno is 4 centimeters in both the cases, Hemant and BH. So similarly, I have applied on the other side. So it is now clear. How does Hemant look like?
So this is Hemant suture in place. This is anterior side, and this is posterior side. So now.
So the uterine compression suture represents a significant advancement in obstetric care, and every obstetrician should be well trained in placing at least 1 or 2 types of compression suture. There are many in market like Pereira suture, this suture, Jang suture. At least you try to learn 1 or 2, and my advice is that at least you should know Billing suture and Cho suture. Now coming to the stepwise devascularization, all of you know that we tie the uterine artery at this level, one upper level and one lower level. Now confusion arises when we tie the ovarian artery. People say it is written in books that it is ovarian artery ligation, but the word ovarian artery ligation is a misnomer. Ovarian artery is a branch of abdominal aorta and we do not tie the ovarian artery. What we tie? We tie the anastomosis between the uterine branch of the ovarian artery and the ovarian branch of the uterine artery, and the anastomosis lies here, just below the ovarian ligament. So we are actually tying it here. We are not tying it here. So it is not an ovarian artery ligation. It is a ligation of the anastomosis of the branches of the ovarian and uterine artery. I think it is clear. So now I am showing you the uterine artery ligation. We use catgut or Vicryl for this. This video is shared by my one of friends, Dr. Soma Mitra. Bladder is pushed down. The cesarean has already been done. Palpating the uterine artery. Take a round wood needle with suture, either catgut or Vicryl. Take 2 centimeters of myometrium, 2 centimeters below the uterine incision, and take it out posteriorly from an avascular window in the broad ligament. Why a vascular window? So as not to prick any blood vessel. And just tight. Catgut is good enough. Or you can use number 1 or number 10 Vicryl. So this is how uterine artery is ligated. Always make 2 turns in the first knot. Distal ligation is then 2 to 3 centimeters below the proximal ligation. Method is same. First bite through the myometrium and the second bite through the avascular window in the broad ligament. Such beautiful avascular window you can appreciate here in this picture. So, uterine artery is ligated here at 2 places, proximal and distal. So, we can move to next. Ligation of the anastomosis of ovarian and uterine artery. See it carefully. First bite through the part of the myometrium. My needle is 10. Suture material is 10. I don't take number 1 here. I take thin needle here. So, 2 bites taken. 2 bites taken. And inside these 2 bites is the anastomosis of the branches of ovarian and uterine artery. So this is all about this ligation. So now coming to the most important part of surgical management, that is internal iliac artery ligation. It is very important in obstetric emergencies, and sometimes we have to do even after obstetric hysterectomy also. And then it is very useful in placenta accreta spectrum disorder. And since time is short, so I'm not discussing the gynae causes now. But what is important is this collateral circulation, which happens in 90 minutes after ligation. So going back to our anatomy classes, this is abdominal aorta at the level of L4 and L5. It divides into 2 common iliac arteries. Now, each common iliac artery at the level of the sacroiliac joint divides into 1 lateral and 1 posteromedial branch. This lateral branch is external iliac artery, which is continued as femoral artery below the inguinal ligament. And this posteromedial branch is internal iliac artery. Now, this is showing an inset of internal iliac artery. This is one-sided common iliac artery. This is lateral side. This is medial side. Now, you see this common iliac artery divides, and this is giving the external iliac artery branch, which is later on continued as femoral. And this posteromedial branch is internal iliac artery. But see, beautifully, this internal iliac artery, as soon as it originates, it gives a posterior branch again, which mainly supplies the parietal part. And this anterior branch is continued, which mainly supplies the visceral part. So we have to ligate the anterior division. This is the posterior division. We have to ligate the anterior division of the internal iliac artery. And this anterior, in a pool of blood in PPH, we cannot see the posterior division. So what we do is that we ligate the internal iliac artery 4 centimeter below the origin from the common iliac artery. And you can make 4 centimeter in your thumb with a scale, and then when you're working on a patient live, then you measure the distance with your thumb. That is the best method. I do this. So we are concerned about the anterior division of the internal iliac artery, out of which the most important branch is uterine artery, then vaginal artery, and then superior vesical artery. And regarding the relation, anteriorly we have peritoneum. But actually what we tell is, we tell that we are opening the retroperitoneum, because this is a retroperitoneal structure. So this peritoneum is basically retroperitoneum. Then medially we have ureter. When we make a flap of when we cut this peritoneum and make a flap, then the ureter always comes in the medial flap. And ureter says that I am a very goody organ. I go to medial side, you do ligation on the lateral side. So what I want to say, that never get afraid of ureter. Then infromedially we have internal iliac vein. We have some techniques to save this, and I will tell you. And then this lies over the psoas major muscle, and this obturator nerve is very far, never comes in our way. So how internal iliac artery works? Bilateral internal iliac artery results in 85% reduction in pulse pressure, 50% reduction of blood flow. So it converts an arterial blood flow into a venous flow. So it facilitates coagulation and bleeding is reduced, and definitely life is saved. It is technically difficult initially, but one picks up it very easily. It is not like learning a laparoscopic surgery. So these are my 2 companions. I performed more than 100 internal iliac artery ligation in last 22 years in Deen Dayal Upadhyay Hospital, where the annual delivery rate is 10,000. So this is a mixture forceps or right angle forceps, which I use. Its tip is not pointed. And this is a double thread. You know, when I was teaching, when I wanted my juniors to assist me in internal iliac artery ligation in the midnight, in different complicated cases, then you got to know what they have to do. I used to tell them, you give me silk, then they are not giving it properly. So this is a picture which I'm showing you for everyone's education, that you have to make a double thread of silk. That's why I've written, I make a double thread, silk number 1 or vicryl. So the double thread is like this. This is a model of internal iliac artery ligation, 3D model. And I'm just showing only a glimpse of that model because we do not have much time here to show it. But whenever you give me an opportunity, then I will definitely show. This is patented by, as sir was saying, patent right, IIL. This is patented by Government of India. So this is a 3D model. I'm just showing a glimpse of this. We can teach the technique and anatomy of internal iliac artery ligation in this.
This is common iliac artery. This is external iliac artery, which is later.
Like if we go somewhere in the middle, then even the sutures can be passed. This is a technique of dissection.
I need to ligate the internal iliac artery.
Then,
and look at the movement.
Then we pass the thread like this, you see,
I will open it
from lateral to medial.
And I will get hold of
So this is a model on which we can show the dissection technique and the method. Now you understand this double thread, why double thread is taken. With this one single thread will make it. So now coming to, this is a 10 minutes video. So this is common. So I'm just discussing this case. This was a case who was delivered by cesarean section at one peripheral hospital in 8 a.m. in the morning, and then she had postpartum hemorrhage. She was again operated under saddle block anesthesia, and then from below the doctors repaired some vault and other things, and then again she was given lots of blood, 4 PRBC, 4 FFP platelets, and then again after 3 to 4 hours she went into shock, and finally she reached me after 11 hours of her delivery. And you know, it is very, very difficult to save patients who is suffering from PPH and coming to you after 11 hours of delivery. So that time her pulse was 140 and BP was 120/70. it looks like her BP was normal, but when I look at the pulse, then her shock index was more than 1.1. So immediately I did not waste even a single minute looking from vaginal side. I just took the patient to OT and opened the patient from right paramedian incision. And when I opened the abdomen from right paramedian incision, I saw a huge broad ligament hematoma and part of rupture uterus. And this was extending along around 10 to 14 centimeters. So I performed a hysterectomy in this case in order to save the life of that primary gravida. And after performing the hysterectomy, there were oozing multiple from the lower part of abdomen and pelvis. So I took a decision of performing internal alligatory ligation. Remember, here I did not perform internal alligatory ligation earlier because the patient was in shock. So I performed a hysterectomy. Hysterectomy is the answer. But if even after hysterectomy patient bleeds, then you have the option of performing internal alligatory ligation. So I'm showing a beautiful video of that. This is a hysterectomized uterus, and this is the pedicle of round ligament. Now, from here we are proceeding. Round ligament pedicle. I've insinuated my seizures and opening the thin peritoneum, and what we call this retroperitoneum. And my direction is towards the lateral pelvic wall, that is parallel to the infundibulopelvic ligament. This is the anterior approach. There is something called posterior approach also. Here I am showing you anterior approach. If I get a complete internal alligatory session, then I will show you. Now you see, as soon as I opened the retroperitoneum, I left all the instruments. With the help of only my 2 fingers, I am separating the loose areolar tissue. Now this is the ureter in the medial flap. Ureter in the medial flap. This is common alligatory. Unless I see it correctly, I will make the dissection more and more to make everything clear. The general principle of surgery is that you recognize your structure very well, only then perform surgery. Remember this. So you see what I'm doing here. I'm separating the loose areolar tissue more with my fingers to make everything prominent. So you see, this is common alligatory dividing into external, internal, and this is ureter in the medial flap. Ureter is not coming in your way. And this is called inverted Y. You have to recognize the inverted Y. So this is inverted Y, the stem of Y, external iliac, internal iliac, and inverted Y, you can say. Unless you see internal iliac, don't proceed. Now I'm palpating the external iliac artery and feeling the femoral pulse. When I'm pressing the external iliac artery, the femoral pulse will go. When I'm releasing the pressure, femoral pulse will come. So this is how I recognize external iliac artery. Now again, I press the internal iliac artery and there is no change in the femoral pulse. Now I've taken this right angle forceps, which I have shown you in my picture, and you just see how I'm separating the sheath, which is enclosing both the internal iliac artery and internal iliac vein below. Just see how beautifully the dissection is being done. They are in a sheath. We have to dissect the sheath. Only at that place, which is our proposed site of ligation, that is 3 to 4 centimeters below the origin of common iliac artery. Now you see, how am I separating the sheath? The direction of dissection is parallel to the vessels. It is never perpendicular, because if I make it perpendicular, this is the vein and I will puncture the vein. This is the vein, this big vein. So my direction of dissection is parallel. Now you see, from lateral to medial, you have, from any side, you have to insert the right angle forces from lateral to medial. Because if I do in reverse, then I will hit the external iliac vein of that side. Now the double thread is already ready. It has to be kept ready. And very gently I pull the double thread. So this is clear, I think, how the dissection is done. The thin layer has to be cut beautifully. And now I've cut the double thread, and with a single thread, I made 2 threads. Why we have to take double thread? To decrease the chances of injury to these big great vessels. In single movement, we are making 2 threads. And I work here very gently. In Hindi, it is said कि दिमाग बर्फ की तरह ठंडा रखना चाहिए, and I keep my head like an ice while I perform this operation. I make no haste, no hurry, never get excited. Now I've recognized which thread is continued with which one, and I get hold of one thread and 2 turns in the first knot. I'm doing here also. Then I'm making the knot, I'm bowing my head, selecting the artery, bending my back and putting the thread just on the superior surface of the artery.
So you see, my fingers are going on the artery. I'm not pulling the artery. And now after applying the knot, I cut it myself. I never pull the artery because there is fear of being torn. So first knot I apply it. Then you see, this is the first knot. And this is the first knot, and I'm about to apply the second knot. It is around 0.5 to 1 centimeter away from the first knot, whether lower or upper, whatever you decide. And similar method. 2 turns in the first knot always. It is a big vessel. It is the third biggest vessel of the body, and the wall is thick. And in fact, one more point I want to give you the tip that when you pass the right angle forceps from lateral to medial, then you gauge your right angle forceps. You see this beautiful bulge here. Can you appreciate the beautiful bulge, Dr. Sneha, Dr. Bhole, Dr. Bhole sir?
Yes, ma'am. Very good work.
In between
Very good
sutures.
demonstration, ma'am.
Thank you, sir. Thank you, sir. So one tip I wanted to give that when we pass the right angle forces from lateral to medial, then the pressure will be more towards the arterial side rather than on venous side, because the bigger the vein, it is thin, and the bigger the artery, it is thick wall. So that is the principle.
And what is the advantage of taking 2 stitches instead of 1?
Yes, sir. Yes, sir. Sir, we are here dissecting the great vessels. And if I pass the right angle forces twice, then I am increasing the chances of injuring the internal iliac vein, which is below, twice. So if in a single movement I can make 2 threads and do, then I'm decreasing the chances of injury to nearby structures. Right, sir? So I can demonstrate all these in my model also.
I just interrupt you. I think what Dr. Bore is asking is why you want to take 2
double
stitches.
ligation.
Yeah.
Yes.
You are passing it as a loop and cutting it into 2. That is good. But why 2? Why not a single ligature? That is what.
Madam, it is a very big. It is the third biggest vessel of the body. It is very big, and 2 sutures may ensure completely that the blood supply has been blocked. So it is always 2 sutures are applied, and one more thing, it is never cut. Usually when we ligate the uterine artery, we cut it. But this is such a big vessel that we do not cut it, because if we ever cut it, then if it ever slips, then patient will bleed to death. So 3 important points with internal iliac artery ligation is this, that first thing, you have to put a double thread, and you have to make 2 threads with that double thread, which I have shown. Second thing, graze the right angle forceps with the artery and then go. Third thing, go from lateral to medial on both the sides. Because if I go from medial to lateral, then that tip of the right angle forceps will hit the external iliac artery of that side and will prick it. And fourth thing, always apply 2 ligatures, 1 centimeter apart. And fifth thing, never cut. Just leave them as it is. I think I'm clear.
Ma'am, how to manage accidental injury to internal iliac vein?
Sir, if accidental injury has happened to internal iliac vein, then first thing, that remove the word panic from your dictionary. Keep a handy bulldog clamp or any vascular clamp in your hand and just apply it nicely or put pressure and call your general surgeon friends. Vascular surgeon available, very good. Otherwise, just call your general surgeon friends and keep a number 3 proline ready. They will come and they will suture it.
Thank you.
I would just share here, there is a Dr. Piley's aortic clamp, aortic clamp. That also, even if you have the major vessel like aorta, it is like C-shaped, it fits all around and clamps. So it doesn't occlude or traumatize the vessel, but it occludes the vessel.
Yes, ma'am. Yes, ma'am.
So what she has said about the abdominal pressure, no? So even if you, when you have opened the abdomen, if you just apply the abdominal aorta clamp, it should serve the purpose. So similarly, if you traumatize some major vessel, that clamp can be used.
Yes, yes. And sometimes one more important thing which we encounter here is, there are many adventitial and peripheral vessels which come from the internal iliac artery. That might bleed. So again, remove the word panic from your dictionary. Just go on doing ligation of internal iliac artery. Once you ligate it, those bleeding will stop. Okay, sir?
Yes, ma'am.
So the technique of passing right angle forceps, this is the correct method from lateral to medial. Remember the word lateral to medial on both the sides. So these are my own tips where I performed more than 100 ligations. So the tips are: open the retroperitoneum from nod ligament to infundibulopelvic ligament. There are 2 methods. Anterior method is which I have shown, and the posterior method is Make an incision 2 centimeter below and 2 centimeter lateral to the sacral promontory. On both the sides, you lift the peritoneum and make an incision and take it to lateral side. So on both the sides, retroperitoneum will be open in that vascular area. Then if I'm opening the retroperitoneum like this and any instrument is in my hand and I keep on doing dissection like this finger, then that my instrument will prick and injure the vessel. So I always say, once you open the retroperitoneum, keep your instrument aside and only with the help of 2 fingers, you separate the loose areolar tissue. So that's why I have written here only finger dissection. Then look at the bifurcation. What is the bifurcation? Inverted Y. Unless you see the inverted Y, you make every method, make the dissection more easy, do more finger dissection to see the inverted Y as I've shown you in my video. Then locate internal iliac artery as a medial structure which does not cause any change in femoral pulse. This I've shown in the video also, and this I show in my model also. When you press external iliac artery, the femoral pulse will go. When you relieve it, it will come. But there will be no change in femoral pulse with the pressing of internal iliac artery. And there is one more point, that it is a medial structure. Then movement of mixture or right angle forceps is always from lateral to medial. Careful knot tying in the cavity, make double turn, and you have to go up to the knot. You have to bow your head and salute the artery. You don't have to pull the artery. Then 2 ligatures 0.5 to 1 centimeter apart. And last but not the least, I've seen it with my own experience. Always do bilateral. And it is later on I searched in the literature. It is written in literature. The chances of real laparotomy and morbidity increases if you come out after doing 1 internal iliac artery ligation. The FIGO in 2022 guideline recommends that internal iliac artery ligation as one of the options to rapidly control postpartum hemorrhage for management of postpartum hemorrhage when medical, non-surgical approaches and compression suture fail. And the FIGO also recommends that all obstetricians familiarize themselves with the internal iliac artery location and with the technique of its ligation. And I can demonstrate both these in my model. I think few of Madam and Dr. Mitra Saxena ma'am, Dr. Anita Razoria ma'am have seen my model. So last but not the least is hysterectomy. And I always say that do it sooner rather than later. And dissection is very easy in a peripartum case, but the pedicles are friable. So always apply double ligature. And in atonic PPH, we do subtotal hysterectomy. It is very fast, can be done in 3 to 4 minutes. But if it is a placenta percreta, if there is a colporexis or anything on the lower segment, then you have to perform a total hysterectomy. So an obstetrician should know both the complete and total hysterectomy, complete and partial hysterectomy. So this is the case of placenta percreta. Every week I perform operation on 1 case of placenta percreta. So you see here, I've done a total hysterectomy here, and I'm applying clamp last below the cervix. And this is the cut section. And one more thing I want to add, which is not written here in the slide, that when you are suturing the wall after obstetric hysterectomy, always apply figure of 8 sutures. Even in gynecological surgery, I apply figure of 8 sutures, because if I take single suture, it will slip, not cause hemostasis. And if I take a continuous suture, then it will make cut through. So the answer is figure of 8 sutures on the vaginal wall. And few cases in my life, I encountered 5 such cases in which after doing hysterectomy, after performing internal iliac artery ligation, still there is bleeding from the abdomen, because those patients, most of them had jaundice or DIC. So what to do? Again, remove the word panic from your dictionary. I packed a few of them with gel foam and Surgicells, few with multiple mops, and in 3 cases, complete full drape sheet I packed throughout the abdomen, lower part, upper part, middle part, everywhere. And the bleeding stopped, patient's vitals improved. And after 48 hours, we have to make another operation with the help of surgeons to remove these mops or drape sheet. And we saved all these 3 patients. I think it is clear to everyone. It is a video, live video on Billy suture. If time is there, then only I will show. Otherwise, I will not show. So with kind, I want to just ask the chairperson, should I stop here, sir?
Yes, ma'am, you can.
So, no, should I show this video or I stop here?
Yes,
this is a
you
live
can show.
You can complete this video, Shashi, and then
okay, ma'am. Okay, ma'am. Okay, so see, this is a live. You can appreciate the atonic uterus here very well. Medical management has failed, and I'm applying Billy sutures in the single suture, 90 centimeter to 100 centimeter length, and the catgut is in my hand. I've taken a bite at point A, now taking second bite at point B.
which is 3 centimeter above the incision line and 3 to 4 centimeter medial from lateral side. Now posteriorly, I pierced it at the level of uterosacral ligament and have come out anteriorly. Then my needle is in the cavity. You can appreciate the atomic uterus here. Then from cavity, again I have come posteriorly at point D. And again, got the suture anteriorly. And at the level of conno, it is 4 centimeter medial. You have to place the thread yourself. An assistant will keep compressing the uterus, and you have to place the thread yourself approximately 4 centimeter. We are not mathematicians, we are surgeons. So now coming out through point E.
I think here I would just say, add Shashi, that whenever you're tying the knots, no, the assistant has to compress the uterus.
Yes, they have to compress the uterus, and she or he has to fix the uterus. If it keep on moving like this, then you can't apply the knot.
Yes, and maybe once or twice you have to retighten the sutures.
Yeah.
Knots.
So now the suture has been taken, billing suture has been taken. Now what I am doing, I've got hold of this with the artery forceps, and now I'm suturing the uterine incision wound. Because once you tie the suture, then you will not get the angles of the uterine incision wound. So this is very important to be noted, that now you close the LSCS wound.
Yeah, so I think you have shown this on a model also.
Okay, and ma'am, right? Yeah, thank you so much. Yes.
So I think you can stop
so
now.
Thank you so much. And I wish that I should go to every part of India to teach these skills and drills so that every mother can be saved.
Yes, I'm making.
And thank you so much for the opportunity.
I'm making it sure that you have traveled to, I think with me, you have traveled to Tamil Nadu and South Indian societies also, and to Maharashtra now. So definitely it's going to be very helpful to the, not only to the newcomers or newly practicing obstetricians, but also the older ones, senior ones who have not, acquired these skills. So I'm very happy to have you, Shashi. Any comments if the chairpersons wants to make? They are.
Yes, thank you, Shashi ma'am. It was very wonderful and informative and nice demonstrative videos actually. I always tell my colleagues or juniors to learn all these techniques of compression suture and internal ligation, because in standalone hospital it is very difficult to manage PPH in limited resources, and we always lose the golden period for saving the patients while shifting to ICU. So if everybody knows all these techniques, we can just save the golden time and we can save the patient also. So thank you, ma'am. Thank you very much. And thank you, Sneha madam, Madan and Monica madam, for giving me an opportunity to chair this session. Thank you very much, and all the best for your future tenures.
Best wishes to Sneha ma'am.
Thank you so much. And
thank you,
Mr. Vilas, our webinars, virtual session, they are not sessions for political.
Sneha ma'am, your internet connection is not working, I think.
Can you hear me?
Hello, Sneha ma'am.
Ma'am's internet connection has gone down.
Can you hear me now? No?
Yes, ma'am. Yes, you are audible. Yeah.
Yeah, the academic session for our committee, we are not organizing academic session just for the sake of, political interest or just for the sake of activities. They are full of information. I'm sure Shashi will agree to this. And every time we choose a different aspect and we invite the stalwarts in the field so that, it is very beneficial. It's not only theoretical. Most of the times I at least have one person to have the demonstrations of the surgical skills. Few of the occasions I do invite Dr. Mahesh Gupta, who nowadays speaks on uterine conservative surgery on placenta accreta spectrum. So I'm sure some of the occasions I will also invite him. So thank you all of you for joining. And purposefully, I have given much time for this operative session because, theoretical aspects you all can read out and we can discuss anytime. But now we go to the panel discussions, and I'm sure all the panelists are learned and experienced. So we are going to have the session in short, and they're going to have the crisp and clear answers, I'm sure. So is somebody there to introduce the panelists? Madan? Dr. Madan Kamre, is he here? Otherwise, I take this opportunity to first and foremost invite you. Yeah. So I think Dr. Anjali has some medical emergency in the family, so she has talked to me. So Anjali was supposed to be the expert for this panel, and I welcome my dear friend Dr. Chandrakant Sanklecha, whom fondly we call Sunil. All of you must be confused who Sunil is here. So Dr. Chandrakant Sanklecha is the expert for this panel from Nasik, senior obstetrician, practicing obstetrician gynecologist from Nasik, and of course he's past president of Nasik OBGYN Society, and I am in Nasik also. So welcome, Dr. Sunil, Dr. Chandrakant Sanklecha.
Good evening, everyone. Yeah.
Good evening. So Anjali Kulkarni, the director of OBSGYN Women's Health Center and Maternity Home Nasik, and she's the current secretary of Nasik OBSGYN Society. Welcome, Dr. Anjali. Do we have Dr. Anjali here? I can't see her.
I think she was here.
So welcome, Dr. Anjali. May I request all of you to please rename yourself so that I can make out, I can recognize. Welcome, Dr. Vishal Patil, the current secretary of Dure OBGYN Society. And of course, he is this, I think, I can see only his accolades, but he is studied in, I think, in the Government Medical College, Dure itself. And he was a treasurer of IMA Dure and of course the secretary of Dure OBGYN Society at present. So welcome Dr. Vishal Patil. I hope he joins soon. Madan, if you can just call Dr. Vishal Patil so that we have started with the panel discussion. Welcome Dr. Sonal Ingre, the consultant OBSGYN from Jalgaon. Dr. Rajendra Bhatia, welcome. Welcome, Dr. Rajendra from Chopra, the practicing obstetrician and gynecology. As somebody has just talked about him as a savior for the practicing obstetrician gynecologist. Dr. Tushar Samre, the president of Malegaon Society, practicing obstetrician and gynecologist since 1999. Welcome, Dr. Tushar Samre. Dr. Sachin Khedkar, do we have Sachin Khedkar here? I think, Madan, can you please give a ring to one or two panelists here? If I can, basically, I can't see the panelists here. So if we have Dr. Sachin, we welcome him. Dr. Monica Singh is the past president of, she will be the president of Bhopal OBSGYN Society, a very vibrant personality from Bhopal, now the organizing chairperson for West Zone Vice Presidential Conference of FOXY, VPCon. Welcome Dr. Monica Singh, the IVF specialist from
Thank you, ma'am. Thank you, ma'am.
And best wishes to you for your candidature as chairperson for Perinatology Committee.
Thank you, ma'am. Best wishes to you also, ma'am.
Thank you. Dr. Anita Rajoria, once again, a very vibrant, active personality. She was my committee member also, very hardworking. And now she is also contesting for the chairperson of Environmental Health of FOXY. So welcome, Dr. Anita.
Thank you, ma'am. Thank you for involving all of us.
Yeah, and Dr. Varsha Lahade. I hope all of you know her well. Past president of Nasik OBGYN and of course zonal coordinator of AMOGS, and she is also contesting for MTP committee. So I don't think she is here. If at all, then we welcome her. Okay, so how many panelists do we have on board? I can see Anita and Monica Singh. So
Dr. Bhatia is there.
Right. Yes, welcome. So
thank you.
Yes. So I think I'm just sharing my screen. Can you see the screen? Can you see my screen?
Yes, ma'am.
I'll just make it full screen. Yes, now. Yeah. So friends, all of you have just heard about the medical and surgical management of postpartum hemorrhage, which is an obstetric emergency. We are going to have this discussion on the medical emergencies during pregnancy. I'm sure all of you agree to me that the demography is changing. The population which is presenting to our obstetric age group is definitely advanced age, and that is the reason they have hello. That is the reason why we have associated medical disorders or various comorbidities, and of course the uh, work pattern, the diet, and the lifestyle leading to obesity, annihilation, infertility, ART practices, and of course the pregnancy associated complications has worsened the scenario and broadened the spectrum of these medical disorders during pregnancy. And that is how we will just talk about, in short. I'm going to make it short. I'm not going to discuss this. I think I have so straightway, without much ado, I would just go straightway to the first case where you have this 36-year-old woman who has conceived with IUI. She was treated for infertility, conceived with IUI. She stays in a village and husband stays or works in Dubai. But for her pregnancy management, she has come to you as a regular antenatal care. And up to 24 weeks, everything was fine. So she was told that things are fine. So she was lost to follow. I can hear some noise, I think. So some panelists, you need to mute, please. So she has come to the NC checkup, come for a NC checkup at 34 weeks with pain in upper abdomen and mild edema. So at a primary health center, she reported where the blood pressure was 176 by 116. And she had mild FGR, proteinuria, etc. Other investigations were not possible there. So just the medical officer started with tablet nifedipine retard for this blood pressure. Then she was advised admission and considered for possibility of some complications and early intervention. So she did not get admitted or went to the higher center. She got admitted around 1.5 days later, where her blood pressure, in spite of tablet nifedipine retard, was 168 by 110. So there the medical officer started magnesium sulfate. They had anesthetist and obstetrician, so they went ahead with cesarean section, delivered that 1.8 kg live female. Her blood pressure remained in the range of 140 to 180 by 100 to 110. So I think I have the names of the panelists wrong. I'm sorry. This is a different presentation I opened, but I will continue with the same. So patient was on tablet nifedipine and magnesium sulfate, continued for 24 hours. Suddenly she went into, she started getting breathless, and her BP was 220 by 118, pulse rate was 115, saturation dropped down to 70%. And chest wheeze was present all over the chest, no clear breaths. What is your differential diagnosis? Anybody can take up that, as we have only few panelists here.
As you have narrated the history, ma'am, this was hypertensive disorder with the severe features. Typical, scenario is there. Now patient, even despite the treatment offered, has landed up in most probably pulmonary edema. So, because she is now, ma'am, can we have the case scenario on the screen so that our audience are benefited? It has gone. Your PPT has gone, ma'am.
Yeah, purposefully, I'm trying to change it by the time. I just I have given you the scenario that with high managed as infertility, conceived with IUI, with 24 weeks, she was fine. Then she is lost to follow. Then she comes with very high blood pressure at PHC, where she was given tablet nifedipine retard. Now she comes to sub-district hospital, gets operated, and she is put on added labetalol tablet. And now she develops this picture. So what is your diagnosis? That is first. What is your diagnosis or differential diagnosis? Whatever it is.
Most likely she has landed up in pulmonary edema.
Okay. So how will you manage her?
So patient needs emergency treatment, and ideally it will be good if she's shifted to intensive care unit and she's under cover of under care of intensivist. We'll prop up the patient, give her intranasal oxygen. First of all, we should be sure about our diagnosis.
Okay,
But
tell me how
we'll keep on resuscitating while we send our investigation. ABC is done as like any other patient. Intranasal oxygen is given. Patient is given fluids. Patient is given.
Is it the ABC, or for this particular patient you have something different?
Because
this
she
case
needs
of pulmonary edema. So what would you do now?
Now, immediately prop up the patient. Call for help. That is important.
Okay.
Because and if you have intensive care unit, it is ideal. Otherwise, you resuscitate the patient and plan for her referral also. But meanwhile, you will give the treatment to her, give her oxygen, prop up, give her morphine, and you have to give her diuretic if you are thinking on line of pulmonary edema. So most likely she's having pulmonary edema in this case. And she will respond.
We are not guiding for this patient, Dr. Anita, whether you will give diuretics or no. That should be your, how will you manage this patient?
Yeah, I will give her, Lasix because she is having pulmonary edema. I'll give her morphine also because
What else?
Morphine is given, and then nitroglycerine should be offered.
We have morphine now. Yeah.
Nitroglycerine should be offered because it is the drug of choice in such patients. So
why is it is the drug of choice?
Because it decreases the preload also. It decreases the preload also.
Okay.
It causes dilatation. So so preload to heart is decreased, thereby having some relief in pulmonary edema. So all these this cocktail of all the drugs will be given together.
Okay. I would ask Dr. Rajendra Bhatia. This
aminophylline can be added, madam.
Yes.
Yeah, and short of steroids also can be added if it is pulmonary edema.
What will be the antihypertensives? I will, if you have...
If hydrolazine available, we can use it.
Yes. So I would ask now Dr. Chandrakant Sanklecha, our expert, that when you have this patient, see, Dr. Anita has already said propped up oxygenation.
Yeah, I'll tell you. Yeah.
What antihypertensives? Yes.
Yeah. See, especially in cases of PIH and severe PIH, flash pulmonary edema is known, and you should always suspect it early.
Yes.
So now we have to approach this patient from 2 or 3 angles simultaneously.
Right.
First is give her Lasix, diuretic immediately. Give her propped up.
Yes.
Second is no nasal oxygen. You have to give her BiPAP.
BiPAP.
Yes.
Because her oxygen saturation is 70, it is not a very, it's not a mild condition.
Yes.
So you have to give BiPAP. Even if the oxygen saturation reaches 95, 96, keep her giving oxygen full. Okay. So that is one. And third is tackle hypertension.
Yes.
Now you have to tackle hypertension actually very fast because many times what happens is in PIH, there is oliguria also and there is fluid overload.
Yes.
So we have to tackle hypertension and restrict fluids. So tackling hypertension, NTG is okay, but hydrolyzing, as Dr. Bhatia said, can be very useful.
Okay.
And
labetalol also can be added. 100
what all options you have, and how will you choose between the? We can have labetalol injectable. We can have capsule nifedipine 10 milligram, the orange capsule. We can have hydrolysine, as you rightly pointed out, and NTG. So of these 4, what will
whatever you are well versed with, almost all are effective.
Yes.
We normally use NTG.
Yes. NTG is the drug of choice, sir. As as happened.
I have been using IV labetalol also.
Yes.
I don't know how much it is effective postpartum. Antepartum, yes, it is definitely the drug of choice.
Yes. So
and nowadays we don't give sublingual nifedipine because it is banned actually.
Not sublingual, oral nifedipine.
Oral nifedipine, yes. It will take some time for the action to come.
Yes.
But
So
what is important
how
is
much time, Chandrakant? How much time? Oral nifedipine also takes around 5 to 10 minutes for the onset
10 minutes,
of
about
action.
10 minutes. Yeah.
30 minutes for the peak action and 6
Yeah.
hours for the duration. So well and
Yes.
good. 5 to 10
Reasonable.
minutes.
Yeah.
Okay.
Reasonable. If yeah. But supportive treatment, especially with high pressure oxygen, propped up and diuretics is very important. And restrict fluids. So
Yes.
I think for all PIH patients, you should be very careful while giving fluids. Never more than 60 ml per hour. Never.
You're right. So that is how, see, this patient was being managed. What you have already talked about, she was given the proper position, and she was given oxygenation, as you said, BiPAP. Injectable labetalol was given. Lasix 40 milligram was given. Only one TPR, not to give Lasix half ml, 20, 40. So
Yes.
40 to 80 at least, 80 milligram at least.
Give 40 stat first, and then you think. Yeah. Correct.
So after 10 minutes, this patient's pulse was not recordable, BP was not recordable, oxygen saturation dropped down to 55%. And with AMBO-assisted ventilation, this patient was shifted to ICU. The patient developed cardiac arrest. Now what next? How will you manage? Once again, I would ask Monica, Anita, and Dr. Rajendra Bhatt again. And do we have the other panelists, if you can, please? I don't see any of them, I think. So we can go ahead. Monica.
Ma'am, defibrillation.
Okay.
Cardiac arrest.
Yes.
She's in ICU. She's in ICU. You have to manage the cardiac arrest and.
So ABCD. Now again.
Again, read.
Okay. So Anita, you can take this forward.
Yeah, so now we manage her like maternal collapse again. It's like having a secondary survey. You do ABCD once again, and you are trying to, start CPR. If she's not responding, you
That
start.
time her BP was very high. Now she's going into cardiac arrest. Her BP pulse is not recordable. Here you will require dopamine dobutamine. Okay.
Yeah. So cardiorespiratory, CPR is started, and other supportive treatment is to be given. And meanwhile, this patient now calls for intubation because her saturation has gone down. She will not, be
But we need mechanical.
okay without.
We need anesthetist for this now.
Yeah,
An
that she already
intensivist.
said that, the call, shout for help. That she has already said. By the time you do this basic CPR, see what it is mentioned that she was, she was shifted to ICU in ambulance with anesthetist. The anesthetist was there already. Okay, in spite
We
of.
must have intubated her.
Yeah. So now she developed cardiac arrest. So immediately she was intubated, and then of course all the
Pressure breathing. Yeah.
So now this patient recovers within 1 hour. Spontaneous respiration, saturation comes to 90%, and
One point.
Yes.
What we have to think of what must be the cause of cardiac arrest.
Yes.
So there are a few things which should come to our mind. One is whether there was any embolus. That is one.
Yeah.
And second, whether there was sudden hypotension.
That was as a differential diagnosis, pulmonary edema or pulmonary embolism.
Yeah, that was one. Second is whether there was sudden hypotension because of very aggressive antihypertensive treatment. Because after developing pulmonary edema and embolism, she has gone into arrest. So parallelly, you have to think of that. And
all the
go
causes from top to bottom as causes of maternal collapse, you have to rule out one by one, because the other causes may be coexistent, as very rightly highlighted.
Agreed.
At this stage, acidosis and electrolytes are also to be corrected now.
Yes. So now definitely you send everything, send her laboratory. By the time, see, you have a team. As you have already said, you call for help. So your anesthetist, physician, intensivist will be there. And then you have your own team of obstetrician and your staff as well. So one person will manage the acute event and along with the anesthetist and your physician. And of course, the laboratory investigations will be said, ABG especially. And then of course you have X-ray, echo by the side. and you are giving this dopamine, dobutamine, and also you are assessing for the primary cause for the ABG, X-ray, ECG, echo, cardiac enzymes also. Yes, you know, sometimes you can have the even cardiac event simultaneously because of very high blood pressure. She can land up into acute myocardial infarction or acute LVF also, as you've said, pulmonary edema.
It can be neurological also, ma'am. At times, you know,
Yes, so everything, that is what the algorithm says. And then because she has spasm also all over, so nebulizer, of course, what drugs to be used? Aminophylline is the drug of choice here. Assisted ventilation, and then of course you have to go for the invasive monitoring, CVP monitoring, and bedside echo. Okay, so this is all. But then you have to introspect what has gone wrong and at what stage. So once again, I start from Monica. She being a IVF specialist, this patient was conceived on IUI. She was treated for infertility. So what do you say about ART pregnancy or IVF pregnancies and the high risk during pregnancy?
Madam, there is a definite correlation between frozen embryo babies.
Yeah, but this patient was, you will say about that, but this patient was on IUI, any type of gamete handling, I suppose.
No, gamete handling is not related to PIH or HDP. It is the age of the patient who are coming for IUI. Yes.
Yeah.
So this age factor is there. Of course, maternal, that family history of hypertension might be, there might be a pre-existing hypertension. There might be, so every IUI, IVF pregnancy at least should be very intensively monitored, especially if the patient is overage with a properly taken history. And and another thing I wanted to say over here, we keep as such also all the patients on low dose aspirin, ma'am, before the embryo transfer. So that has really that really works well for reducing the incidence of PIH in my center.
Yeah, so I would suggest, Monica, that it's not only the IVF, IUI pregnancy, but every pregnancy where you have to analyze the maternal characteristic, the age, BMI, family history or personal history of all these disorders of hypertension, diabetes, vasculopathies, and hypothyroidism, which is a major, scoring factor or high risk factor, which we score it as 3 in the justosis, HDP justosis 4. I think we have to start low dose aspirin and high dose calcium, that is 1.5 to 2 grams. So, Anita, I would tell you.
Ma'am.
Now preconception. Yeah, wait. Preconception, Monica has talked about. You will say how it was missed during the early pregnancy. Why? What was missed? Yeah.
Yeah, there are so many lost opportunity, ma'am. As such, being high risk, you very rightly said, justosis score already is 3. She should have been started on low dose aspirin as early as possible, and she should be kept under good observation. The poor lady did not get even regular antenatal checkup because there was no one to carry her to the hospital. So that was another lost opportunity. And even if she was not able to come, she
what
could
about
have
early pregnancy screening?
Yes, early trimester and we scan
Dr.
also.
Rajendra, you can take this forward. What
Yes, madam. There have been IUCUG guidelines on early pregnancy scanning, the uterine artery Dopplers and algorithms, available to detect high risk kind of patients who can go into PIH. So that must be offered. Fetal medicine guys are doing a lot of work on this.
Speak because I do a lot of fetal medicine.
Even me as a routine obstetric practitioner, we are also following.
We can do basically uterine artery Dopplers in early pregnancy for second trimesters, and we can take the ISUG scoring as well. It is available on their website. If you are a member, you can just put in the parameters that they ask for, and you can get a score like how high, and they suggest the low dose aspirin as early as possible and close monitoring of the condition of the patient so that you can identify the hypertension early and treat it well.
Yes.
And another missed opportunity was she was not referred timely.
Yes.
Yes.
So
even
if Anita, up to this, just to sum up that maternal characteristics and the early pregnancy screening, biophysical and biochemical test taken combined gives you 100% detection rate for HDP.
And the
Okay, so we have
percentage
missed that. And then
we
how it was
estimate,
missed later on when she reported the blood pressure was 176 by 116. What should have been the antihypertensive then? As we have already discussed, she was given tablet nifedipine retard, which is such a small thing, which is used for mild or non-severe hypertension. Okay, so at many opportunities were missed for managing her. So we come to the next case here now. We have this XYZ 20-year-old primary gravida 9 months amenorrhea. She was referred at around late night. She was referred and she was admitted at a nearby nursing home from 3 p.m. onwards, maybe around 8 to 10 hours of strong labor pains. And since she was not progressing, she was decided to be taken for cesarean section. So the staff nurse catheterized her, found that there's no urine, and so they referred. So they inquired about her urine output. There was absolutely no urine output over last maybe 10 to 12 hours where she was observed, and that is why she was referred to some other hospital where the patient's blood pressure was 110/70. Tachycardia, and she was having very severe pain in abdomen. Uterine contractions were very severe, not relaxation in between, and of course the fetal heart was 100 only. Cervix was 3 centimeter dilated, membranes were absent, station was 0, but altered color bleeding was there. So what is your diagnosis? I would ask Dr. Rajendra now. I think we can take this ahead.
Yes, ma'am. It is antepartum. Most likely it is antepartum hemorrhage. And patient is bleeding inside without revealing the bleed outside.
Okay.
So that is causing her hypovolemia and renal early renal compromise, where the urine output is reduced.
Yes.
We should quickly investigate her, correct her hypovolemia, and get blood components ready. Also, possibility
now
of
she's
DIC.
got fetal distress and she's got this coagulopathy, which was
So coagulation profile should be done.
Yeah.
And blood should be arranged as fast as possible.
So whether you would like to wait for the blood and blood products to come, or you will take her up for cesarean section?
No, madam, we should be taking her up for cesarean because that will save the baby as well as relieve her antepartum hemorrhage. But only thing I should need bleeding time, clotting time at least done at the bedside, and it should not be very prolonged so that we can go ahead surgically.
The investigations, if it is prolonged, the bedside investigations were otherwise not done, but it should be done. I'm sure clot retraction time and clot lysis time, these are the two investigations which
at least bleeding time, clotting time on the hand by the
doesn't
bedside.
get affected till late, but here they have provided you fibrinogen 150 mg/% and FDP, fibrinogen degradation products are present. Now what is your diagnosis? And will you still like to take her up for cesarean section in this situation?
Not immediately, ma'am. Then we'll have to arrange for fresh frozen plasma components and all those things.
Yes.
But we'll have to refer it to a tertiary center if I don't have that at my hand.
Okay, Sunil.
Again, she is a clear case of abruption.
Yes.
The more we wait, the worse she will become.
Yes.
So you have to act very fast. First thing is arrange for fresh frozen plasma, as Dr. Bhatia said. Very important because fibrinogen is okay. Still, it is 150 is not very bad. Come on. Platelets are 1 lakh. Okay. And so you can go ahead with the section as early as possible, immediately. Unless you remove the placenta and the clots, she will not going to.
This is very important, sir.
Is not going to reverse. Yeah.
Yes.
So reversing this. And another thing is, because she is anuric, it looks like ATN, acute tubular necrosis.
Yes.
Okay, which is usually reversible.
Usually
reversible. Yeah. Once the her hemodynamic parameters are stabilized. So I think quick action with immediate cesarean section and sending blood for fresh frozen plasma. If you don't have it, you can transfuse non-cross-matched cryos core immediately.
Yes.
Because if it is prolonged, they will tide over because you don't have to cross-match it, and the shelf life of cryoprecipitate is about 1 year. Okay, so you can actually store it as a tertiary storage center also,
Correct.
and you can utilize it till the time fresh frozen plasma is available.
Correct. So very well sum up. I would just say that this, this whatever she has landed up into is abruptio placentae with acute tubular necrosis, that is acute renal failure, which you have very well said that it is, because of hypovolemia and hypertension of the kidney, and that is why you must treat the hypovolemia aggressively. Everything has to be done simultaneously. You have to treat the hypovolemia. Maybe meanwhile you can get blood and blood components, whatever is possible. Try to infuse them and try to arrange for cesarean section. Get rid of the placenta, deliver the baby, because abruptio delivery interval, as all of you know, that the more the placenta separates, even the baby you may lose the baby, and at the same time the DS is going to be worsening. So that is how the abruptio delivery interval is very, very important. So you have to take care of that, deliver and get rid of. Now what precautions during the procedure you have to take?
There is very high chance of atonic PPH.
Yes.
There is invariably you come across a coelar uterus, a black colored or dark colored uterus.
Yes.
So be ready with all the preparations of tackling atony.
Yeah.
And infuse lot of fluids, crystalloids, till the time you get blood products.
Yes.
She just assess the amount of bleeding that has taken place inside the uterus. That is the clot. So normally, if the clot is, let us say, 700 grams, then the bleeding is 1.5 liters.
Correct.
Now, to counter that, you have to infuse 3 times the crystalloids. Okay, because only 1/4 of the crystalloids remain in circulation. If she is in hypovolemic shock, you have to build the circulatory volume also till the time blood products are ready. So parallelly, you have to do all these things.
Yeah, there is a rider, sir, regarding this particular patient. Like, okay, 1.5 to 2 liter we will give for resuscitation, but do not overhydrate, because it will cause otherwise
Again, she is anuric, so she will end up in pulmonary edema.
And that
So,
is why the role of
dilutional
CVP monitoring here. So when you have this very aggressive fluid therapy, then definitely the role of invasive monitoring will come, and of course we'll have to go for CVP monitoring.
And
But then you
dilutional
have to
coagulopathy
transfuse.
is there. We have to be careful and arrange for blood products well advanced in time, because your cryoprecipitates, your fibrinogen, it will need some time to come to room temperature to get infused. Do not infuse very cold blood products, because we must remember that all whatever coagulation factors we have, they work only at room temperature, body temperature, sorry. So don't infuse very cold.
Facilities for warming the IV fluids also. You should have because such rapidly when you are transfusing or infusing the fluids,
absolutely,
you should have the facilities to warm up also.
One more point, please do not infuse platelets unless they are less than 50,000. They are of no use. They start getting broken down immediately as soon as you start giving them.
Yes,
absolutely.
1 lakh is quite okay, kind of a thing. You can easily do cesarean on 1 lakh platelets.
Yeah, 1 lakh looks good.
Yes.
FDP, fibrinogen, 150
there is no
looks good.
question of platelet transfusion here. There is no mention.
No.
So you have to correct.
No. Some people give because some people just initiate the massive blood transfusion protocol and give 1:1:1. That is 1 red cells, 1 plasma. But no, in this case, no platelets.
It should be only the packed cell as to plasma 1:1. No platelets, absolutely. It is only adding fuel to the fire. So you have to correct the hypovolemia, you have to correct the coagulation factors as well, you have to correct restore the hematocrit, electrolytes, everything, and then the targets of therapy, all of you know, I'm not going to discuss this, only
and sometimes at cesarean the uterus is well contracted.
Yeah.
But many times it can go in atony slightly later, maybe after an hour or so. So normally what I do is I ligate uterine arteries anyway. So not to take a chance just in case. Because tying uterine arteries is not going to harm her in any way, but it may help in some way.
Here I would just say that I don't know what is your experience, but even the evidence and even the experience about carbetocin is very good if given as a prophylaxis. carbetocin doesn't act in cases of, it doesn't act as therapeutic for PPH, but as a prophylaxis, definitely it acts.
Yes.
And the time
And it's a
covered
long acting
8
also.
to
Yes.
16 hours. Yes. So the oxytocin infusion you require for around 16 hours. So one single shot of carbetocin takes care of this if given in time. Okay.
Yeah.
So that is about the last case. And now we have this grand multipara admitted to emergency. I think this case we will finish, but this is a very interesting case. Grand multipara admitted to emergency ward late night, and she came as a case of obstructed labor. Pulse rate 110, BP 130/80. Otherwise, okay, only maternal exhaustion, but thick meconium stain like her. Okay, so with antibiotic cover and all the preparations for pre-operative precautions, she was taken up for cesarean section. 4 kg baby delivered. There was little baby resuscitated, and everything was okay. So during the procedure, slight extension of the uterine incision was there, but it was repaired very well. There was absolutely no bleeding inside. After shifting this patient to postoperative, around an hour later, the blood pressure suddenly dropped to 80. Okay, pulse became thready, disturbed respiration, confused look, drowsy, and vomiting tendency she had. On examination, she wasn't pale. There was no pallor, though there was no signs of internal hemorrhage. The abdomen was sourced. There was absolutely no bleeding externally. So that means this is okay. She has collapsed, but there is no external or internal bleeding. So what is your diagnosis? Once again, we start from, I think, Dr. Anita or Monica.
Embolism? Yeah, Monica, take, please. Now, again, all the causes of maternal collapse have to be quickly, ruled out. So it can be anything. Even if it is not revealed hemorrhage, it can be concealed hemorrhage once again.
Foremost, how will you start managing her? Her blood pressure is 80 and pulse is 30 and disturbed respiration.
So again, ABC, airway, breathing, circulation, we have to give 2 liters rapidly. We have to infuse and call for help, call for team members, and one will become the team leader, and we will keep on guiding the rest of the team, because she looks confused also. One person will send all the investigations, and I will arrange for quick infusion of at least 2 liters of fluid, arrange adequate blood for this patient, and send all the investigations, because investigations will give us some clue what has gone wrong for this patient.
This looks more like embolus.
Can be anything. It can be a cardiac event. It can
Sudden
be anything.
embolus.
Yeah. Okay.
Cardiomyopathy usually does not present
manifest.
in such a dramatic or sudden way, but it can.
It can.
It can
be
so
cardiac
PPCM has to be kept in mind.
PPCM as one of the DDs.
Yeah.
One.
So
Pulmonary
3
embolism,
things.
amniotic fluid embolism, whatever.
Yeah.
But what
one is embolism, other is
After-
pulmonary edema, and third is PPCM.
So when you are
these 3 has to
suspecting
be-
pulmonary edema, will you infuse her with rapid fluids?
No.
That is why you have to differentiate the diagnosis then and then only.
Correct. So how do you do it?
Bedside, I
One
give
is-
you a clue. What bedside investigations you can do? This is a
Get
non
immediately ultrasound, do a focused ultrasound. It will give you some idea. And moreover,
My
pulse
dear,
oximeter,
we are very
pulse
good
oximeter.
at clinical acumen. She is
Yes.
not pale. Her abdomen
She's not
is
pain.
very tough.
Put a pulse oximeter also. It will guide you all.
Yes, so pulse ox is already there.
Yes,
So it is showing you the tachycardia, and maybe the saturation is also, till now it is good. So what bedside investigations can tell you? I'm sure
X-ray, because disturbed respiration, one bedside X-ray can be done, and we can do a rapid focused ultrasound also, ma'am. We can see the, lungs also for any.
No. She is confused and she is drowsy.
Yes. I'm sure all of you will laugh at it.
And
sorry why I did not think about this. Okay, now I give you the diagnosis. But before that, I tell you what are the clues here. Grand multipara. large size baby, obstructed labor, previous 3 vaginal delivery or 4 vaginal delivery, now she has got 4 kg baby and
Rupture
otherwise
uterus.
uneventful, large baby.
No, sudden hypoglycemia.
Sudden hypo. You are
Rupture.
coming closer. You are coming
Blood
closer.
sugar.
This is not
Sugar,
hypoglycemic.
sugar.
Bedside, you just take a prick and do sugar. It is 600 or 500. Okay.
Okay.
Spleen sugar 3+, ketones 2+, diabetic ketoacidosis.
Ketoacidosis.
Okay. So I always discuss this case. All of you know how to monitor and manage. All of you have good friends in, as a physician, they will come for your rescue. But the simple test, once single step 75-gram glucose OGTT as a universal screening. Okay. If we had done this at first visit, maybe if missed at 24 to 26, 28 weeks, and maybe in the third trimester also, we would not have missed this, and we would have given appropriate management for this patient, and definitely we
So
would.
this was a missed GDM leading to DKA.
Yeah. So that is very, very interesting actually.
Yes.
This is a real case from Ahmedabad, and this doctor was sued for 1.5 crore. This is a case which Dr. MC Patel also discusses in his talk. Okay. So that is the reason I have included this, that simple mistake of ours is not pardonable by law.
I also saw a similar case, ma'am. She had come from remote area with ruptured uterus. Pulse
Yes.
BP were maintained. I was wondering why she has lost consciousness, and blood sugar was 600. Thankfully, it struck, and we could, it was also diabetic keto.
That
And
is
she
why
came.
always, don't rush for investigations. Try and do the basic management, but do your bedside investigations. At least HB1 prick, if your laboratory friends also can help you. But sugar, all of us have glucometer. Go for, urine dipsticks. They will give you the clue. So simple that I'm sure all of us, if we get such cases in future, we will always think of, either hypoglycemia or diabetic ketoacidosis. So this is, of course, aggressive fluid management, correction of hydration, and giving the insulin infusion. All of you know this. So I'm not going to the learning lessons only. The diabetic ketoacidosis during pregnancy is a medical emergency. It presents a non-hemorrhagic shock, and both the mother and fetus are at risk. Luckily the baby was delivered by cesarean section. Otherwise, if she had gone, prolonged obstructed labor, dehydration, and all these things have led to this situation. And that is what the message is, that we have to maintain the sugar levels and hydration very good during labor for such, not only her, but for all the patients, I would say. There was a case which was discussed earlier, which landed up into coma. That was because of hypoglycemia. Okay, so sugar levels are very, very important. It can be a life-threatening complication. That's the only message I want to give here. Otherwise, no theoretical discussion. We have lots of cases, but I don't think we should discuss it now. It's quite late also. So we stop here. And from my side, first and foremost, I thank the AMOGS team. And of course, I thank the President Secretaries of Jalgaon, Dhule, Nasik, Charisgaon, Malegaon, and all the team members. Especially, I thank all dear friends, the panelists, Dr. Monica Singh, Anita Rajodia, Dr. Rajendra Bhatia, and of course, Dr. Chandrakant Sanklecha, who is the expert. I can see Dr. Vinod Chaudhary, is it? Please unmute yourself. Please unmute yourself. Unmute kara. You can speak, please.
Hi, madam.
Hello.
We can hear you, sir, now. Yes.
Yeah.
I'm Dr. Vinod Chaudhary, Vice President of Jalgaon Obstetrics Society.
Good. Welcome.
Okay.
Yes. So, in fact, we missed you for the panel discussion, but we really enjoyed it being with your society, and we are very happy to organize this webinar with your society. So, thank you, Dr. Vinod Chaudhary, for having us here. And I thank everybody and hand over to Dr. Madan just to say the formal vote of thanks.
Thank you, madam.
Thank you, everyone. Enjoy.
Thank you, ma'am, for making us scratch our brains.
Great.
Thank you, ma'am.
Actually, sorry, I was stuck up in emergency.
No problem, no problem. So
Yes, Neha ma'am, your panels are too good. Your panels have given a lot of revision to me at least.
I see all over India, wherever I moderate the panels, no, they all the time the society says, Neha madam, next time आप इस subjects पे लेंगे. So I have to keep.
मैम 1 घंटे का रखा करो, आपसे बहुत कुछ सीखना है. At least 1 hour का पैनल होना चाहिए. आपके फेसेस बहुत अच्छे होते हैं.
Thank you, my dear. Thank you so much. And special thanks to Sunil, who joined on my request, in spite of being
My pleasure. I enjoyed.
Thank you, Sunil.
Yes.
Thank you so much.
Thank you all. Thank you all on behalf of AMOGS and Madam's committee, Emergency Obstetrics Committee. Thank you all the dignitaries, all the faculties.
I can see my dear friend Arun More also. Dr. Arun.
He's there. Yes.
Yes, he's there.
Hi, Arun.
Hello, Arun.
Hello.
Hello. So thank you for joining. Just the panel discussion संपले आमचं medical emergencies वर.
ओके. मी इंटरमिटंटली बघत होतो, मध्ये मध्ये मला अटेंड नाही करता आलं, तर त्यामुळे मी हे नाही करू शकलो. पण टॉपिक्स वेर नाहीत. आय सॉ that madam showed how to take the stitches in especially for PPH. That was very nice presentation. हे सगळ्यांना कसं ट्रेनिंग मध्ये स्टिच कसा घ्यायचा. हाय सुनील.
हाय अरुण मी बघतोय. Yes.
So that was really nice, because many a times the especially juniors and students do not come to know how to take the stitch properly. So all those constructive stitches were very nice. It was really good. So whatever I could attend in between, that was really nice.
Hi, Urmila. Hi, Urmila.
Urmila, hi.
We can see you.
No, thank you for giving me
nice
opportunity to be as a guest of honor. Thank you.
It's our pleasure, Arun. चल बाय.
Thank you.
Bye.
मराठीमध्ये अपील करते, सर्वांनी वोट करा, फक्त वोट नका करू.
सगळ्यांना सांगा, सगळ्या ओळखीच्यांना सांगा. Yes.
And bless me and Monica also. Me for
नक्की मॅडम,
नक्की. Sure.
Thank you.
चलो bye everyone. Good night.
Bye.
Good night everyone.
So Monica, all set for the